All right, so a very good evening, everyone. So I welcome you all to this quick revision of the entire general medicine. So yesterday, like we are done with the cardiology and as well as the endocrinology. Some two or three topics which are left in cardiology, I'll discuss today. That is like rheumatic fever is left out, cardiac tamponade is left out, and the coronary artery disease is left out in the cardiology. So these three topics, I'll just discuss them at the end of this particular session today. Okay, and the today's revision session will be on the neurology, that is CNS, and as well as the nephrology. And those students who are attending these sessions for the first time, let me tell you, I am myself Dr. Rajesh Gubba. I am the general medicine educator. And the PDF or the PPT of this notes have already been sent to you on the Telegram channel of Dr. Bhanu Prakash. Or it has been also sent to my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So just go to the respective channels, either of it, download the PDF, then just sit and relax. Okay, you don't have much to write, you just sit and listen and then relax. And immediately after the session, I'll be sending you the PDF with annotations also. Yesterday also, like there was slight delay in sending the PDF with annotations, but today I'll try my best to see that the PDF with annotations is being sent immediately after the session. Okay, so having said this, let us start the today's neurology quick revision. So the first important topic, just a minute. Right. So the first important topic will be the autoimmune disorder, that is myasthenia gravis. So myasthenia gravis, if you observe, it is the disorder of the neuromuscular junction. So first and foremost, the very important question here is, all of the following are the neuromuscular junction disorders except the options are Lambert myasthenic syndrome, botulism, congenital myasthenia, then tetanus. So which among the following is not the neuromuscular junction disorder? Any one of you, please? Right. So please remember, it is your tetanus which is not a neuromuscular junction disorder. The remaining all, Lambert-Eaton myasthenic syndrome, botulism, and congenital myasthenia, all these are the neuromuscular junction disorder. Now, let me take up the discussion of the myasthenia in detail. So, if you take the myasthenia gravis, what exactly is it? Myasthenia gravis, it is a dysfunction of which particular gland? Pineal gland, thymus gland, pituitary gland, parathyroid gland. So please remember, it is the disorder of the thymus gland. Now, you should also know what are those thymic abnormalities. These thymic abnormalities, they include the two, that is thymic hyperplasia and as well as thymoma. But the question that will be asked to you is, which is the most common thymic abnormality that will be responsible for the development of myasthenia gravis? That will be your thymic hyperplasia, right? Now, what exactly is the pathogenesis in myasthenia gravis? So if you observe here very carefully, myasthenia gravis, it is the disorder of postsynaptic nerve terminal disorder, right? So you have a neuromuscular junction in which you have a presynaptic nerve terminal and as well as the postsynaptic structure. Now your myasthenia gravis, it is absolutely the disorder of the postsynaptic nerve terminal. Now if you see this question here, myasthenia gravis is associated with, the options are, right, the options are decreased acetylcholine at the nerve endings, decreased myosin, absent troponin C, decreased myoneural junction transmission. So please remember, in these patients with myasthenia, there will be decreased myoneural junction transmission. Let me tell you, the acetylcholine levels at the neuromuscular junction will be normal in patients with the myasthenia gravis. Right, normal acetylcholine levels will be there, but acetylcholine will not have the adequate place to bind to the NM receptors, because NM receptors are occupied by the antibodies. So thereby there will be decreased myoneural junction transmission, but acetylcholine levels will be absolutely normal. And this myasthenia gravis, it is associated with HLA. And what is the HLA association in myasthenia gravis? That is a HLA-B8 or the HLA-DRW3. So in this group of individuals, there is increased risk of myasthenia gravis. And always remember, all these autoimmune disorders, they are friends with one another. So if you are there, I will also be there along with you in the person, and let us kill this fellow, right? So that is what is the tendency of your autoimmune disorders. So now myasthenia gravis, which is an autoimmune disorder, it is associated with other autoimmune disorders like thyroiditis, Graves' disease, rheumatoid arthritis, and as well as the systemic lupus erythematosus. So these are the associated autoimmune disorders. Now the next important question for you here is, all of the following are the features of myasthenia gravis except spontaneous remission, absent deep tendon reflexes, proximal muscle weakness worsened by exertion. Now, which is the incorrect statement related to the myasthenia gravis? Any one of you, please? Which is the incorrect statement? Right. So, if you take this myasthenia gravis, let me tell you, the absent deep tendon reflexes will not be there. So, the deep tendon reflexes are rarely involved in patients with the myasthenia gravis. Okay, that's a very, very important point that you need to remember. And spontaneous remission, yes, it will be there in myasthenia gravis. Once the individual takes rest, immediately the patient's energy levels will return back to normal. Okay, spontaneous remission will be there. And what about the muscle involvement? Proximal muscle involvement is much more than compared to that of the distal muscle involvement, right? Proximal muscle involvement is much more than compared to that of distal muscle involvement. That is also the true statement. And the features of myasthenia gravis or fatigability increases on exertion, but deep tendon reflexes will be normal. So that is the incorrect statement related to myasthenia gravis. Now, in myasthenia gravis, you need to know what is the earliest muscle that is being affected. So please remember, it's a very, very important point. The most common muscle which is being affected will be the ocular muscle, that is levator palpebrae superioris muscle. Now, because of the involvement of levator palpebrae superioris muscle, like what will be the presentation of the patient? The presentation of the patient will be in the form of the asymmetrical ptosis. Now, you need to understand why most commonly the levator palpebrae superioris is commonly affected. Because once we get up early in the morning until the time we sleep later in the night, the muscle which is being used continuously, I mean to say, the skeletal muscle which is being used continuously will be your levator palpebrae superioris muscle. Because in myasthenia, it is the skeletal muscles which are commonly affected. It is not your smooth muscle or the cardiac muscle. Okay. And not only that, the number of NM receptors in levator palpebrae superioris are few. That is the reason why the one which is being affected early is your levator palpebrae superioris muscle. Now, there is also involvement of muscles of mastication, right? What are those? Medial pterygoid and as well as the lateral pterygoid, and masseter and as well as temporalis. So because of the involvement of masticatory muscles, the individual will have difficulty in chewing or they will have jaw claudication. So the classical history will be like, you talk to this patient or you talk to this person for an half an hour or 1 hour, and after that you ask him to eat, he will not be able to eat. So there will be jaw claudication, and there will be also facial muscle weakness. And because of the facial muscle weakness, the individual will have an abnormal facial expression whenever he want to keep an expression, or they will have a characteristic smile, and that we call it as the myasthenic snarl. And the other muscles which are affected is the muscles of deglutition and as well as the lingual muscles. So these are all the muscles which are affected in patients with the myasthenia gravis. And in patients with myasthenia gravis, let me tell you, there will be sustained up-gaze palsy, right? Sustained up-gaze palsy. Now, what exactly you understand by the word sustained up-gaze palsy? For example, if the patient is coming to you early in the morning as your first patient in your OPD, what may happen, right? So he may not have the ptosis because he has got up early in the morning and directly coming to you. But you just keep the finger above and you ask the individual to look upwards continuously. So as the time progresses, there will be utilization of the acetylcholine. Further neuromuscular transmission does not occur, and there will be development of ptosis, and that we call it as the sustained up-gaze palsy. So these are the characteristic features in patients with the myasthenia gravis. And let me tell you, the other muscles, apart from the muscles which are supplied by the cranial nerves, the other muscles which are being affected is the proximal muscles of the limb, and even flexors and extensors of the neck are also affected. And remember, proximal muscles are more commonly affected than compared to that of the distal muscles. And let me tell you, the deep tendon reflexes are rarely involved in these patients with the myasthenia gravis. And there is no sensory loss in patients with myasthenia gravis. There is no sensory loss in patients with myasthenia gravis. Now, the next important discussion, yes, you see this clinical scenario. A 50-year-old male presented with complaining of ptosis, difficulty in chewing, and occasional difficulty in swallowing, right? And there is no history of diplopia or the visual loss. On examination, there is asymmetrical ptosis and mild restriction of extraocular muscle movement with finger abduction test up to 60 degrees. Now, nerve conduction studies show decremental response in orbicularis only. Electroretinography shows myopathic pattern, and antibody, that is anti-acetylcholine receptor radioimmunoassay, is negative. What do you think is the most likely diagnosis in this patient? Right. What do you think is the most likely diagnosis in this patient? Ocular myasthenia gravis, generalized. Third option, as antibody is negative, you need to consider the alternative diagnosis. Fourth option is chronic external ophthalmoplegia. So, what exactly is the diagnosis in this patient? Right. No, it is not generalized myasthenia gravis. It is the I'm very sorry. It is not ocular myasthenia gravis. It is the generalized myasthenia gravis. Why? Because see, to call it as ocular myasthenia gravis, you should have only ocular manifestations. What are those only ocular manifestations? Ptosis, diplopia, and as well as the orbicularis oculi weakness. But if you take in this patient, along with this ocular manifestations, this particular patient is also having difficulty in chewing. There is difficulty in swallowing. So that is the reason why we cannot consider ocular myasthenia gravis. This patient is considered to be having generalized myasthenia gravis. Now, what about the antibody? See, if you take the antibody sensitivity, the antibodies are present only, the sensitivity of this antibody is only 80%, right? The sensitivity of this antibody is only 80%. In almost 10 to 20 percentage of individuals, the antibody will be negative. Now, in case of the ocular myasthenia gravis, what is the antibody or what is the investigation of choice? The investigation of choice will be the anti-musk antibodies. In ocular myasthenia gravis, it is anti-musk antibodies. Whereas generalized myasthenia gravis, it is anti-acetylcholine receptor antibodies. And what is the drug of choice in ocular myasthenia gravis? That will be your prednisone. Now, if you get this particular question like, what is the most sensitive test for the diagnosis of myasthenia gravis? You see the options: antibodies, repetitive nerve stimulation, positive hydrophonium test, and measurement of the jitter by single fiber electromyography. Let me tell you, the most sensitive test will be measurement of jitter by single fiber electromyography. Now, you take, these are the four important investigations: antibodies, repetitive nerve stimulation test, single fiber electromyography, and hydrophonium test or tensilon test. So among all these, the one which is having the highest sensitivity is your single fiber electromyography, which is having 99% sensitivity. Antibodies, what did I tell you? The sensitivity is only 80%. And what is the second most sensitive test? That will be your hydrophonium test or tensilon test. So now this is your tensilon test or hydrophonium test. Once you inject this hydrophonium or tensilon, immediately the ptosis will disappear, and that is what is called tensilon test or the hydrophonium test. So what is this tensilon or hydrophonium? It is basically acetylcholine esterase enzyme inhibitor, and it will increase the acetylcholine levels. And whenever you are doing this tensilon test, you need to keep the atropine ready because the individual may develop cholinergic crisis. So while doing the tensilon test, the atropine should be ready. And the next important PYQ is the IcePack test is due for myasthenia, multiple system atrophy, hyperparathyroidism, hypokalemic periodic paralysis. That is your myasthenia gravis. Now, whenever you do this IcePack test, there can be increased neuromuscular transmission. And because of this increased neuromuscular transmission, the ptosis will disappear. And that is what is your IcePack test for myasthenia gravis. And the next important question is, what is the drug of choice for myasthenia gravis? Galamine, succinylcholine, D2-bucrarine, and pyridostigmine. So please remember, yes, anyone want to make a quick attempt of this question? Right. So, So the drug of choice for myasthenia gravis, it is the pyridostigmine. And what exactly is your pyridostigmine? It is the anti-cholinesterase enzyme inhibitor. What it will do, it will increase the acetylcholine levels, and usually it is given in case of mild to moderate forms of myasthenia gravis. But whereas in severe form of myasthenia gravis, the drug of choice is the prednisone. And we have another important form of myasthenia gravis, that is called myasthenic crisis. What do you understand by the word myasthenic crisis? Where there will be involvement of respiratory muscles causing type 2 respiratory failure. That is called myasthenic crisis. And here the drug of choice will be intravenous immunoglobulin, or you need to do plasmapheresis. And what about role of thymectomy in patients with the myasthenia gravis? Let me tell you, thymectomy is done in all the patients of myasthenia gravis between the puberty and as well as 55 years of age group. It is done in all the patients. Okay, so this is in toto about your myasthenia gravis. And one more neuromuscular junction disorder is Lambert-Eaton myasthenic syndrome, right? So I'm just going rapidly because it's a rapid revision, okay? And so don't worry about writing part, right? Already I have sent you this particular PPT on my Telegram channel. So you can just download that PPT from that, okay? That is Medicine Made Easy by Dr. Rajesh Gupta. Right. Now you see the next one, Lambert-Eaton myasthenic syndrome. Which of the following is correct? It commonly occurs, it commonly affects the ocular muscles. Neostigmine is the drug of choice for this syndrome. Repetitive electrical stimulation enhances the muscle power in it. It is commonly associated with adenocarcinoma of the lung. So, what do you think is the correct statement in this particular question? So, now, if you take this Lambert-Eaton myasthenic syndrome, primarily it is associated with what? It is not associated with adenocarcinoma. It is associated with small cell carcinoma of the lung. And commonly affects the ocular muscles? No, it is the proximal muscles which are commonly affected. And neostigmine is not the drug of choice. It is 3,4-diaminopyrimidine, which is the drug of choice. And repetitive electrical stimulation enhances the muscle power in it. That is the investigation of choice in Lambert-Eaton myasthenic syndrome. And you have to remember that Lambert-Eaton myasthenic syndrome, it is a presynaptic nerve terminal disorder. Whereas myasthenia gravis, it is a postsynaptic nerve terminal disorder. Whereas this is a presynaptic nerve terminal disorder. And in Lambert-Eaton myasthenic syndrome, the antibodies, they are formed against voltage gated calcium channels. They are formed against the voltage gated calcium channels. So what is the difference of Lambert-Eaton from myasthenia? Remember, myasthenia is postsynaptic, whereas Lambert-Eaton is a presynaptic. Whereas in myasthenia, the antibodies are acetylcholine receptor antibodies, whereas Lambert-Eaton, the antibodies are formed against the voltage gated calcium channels. Myasthenia, ocular muscles are commonly affected. Lambert-Eaton myasthenic syndrome, proximal muscles are commonly affected. Okay, and in case of myasthenia, the most sensitive investigation is single fiber electromyography. Whereas Lambert-Eaton myasthenic syndrome, it is the repetitive nerve stimulation test. Okay, and myasthenia gravis is associated with thymic tumors, whereas Lambert-Eaton myasthenic syndrome is associated with small cell carcinoma of the lung. Myasthenia gravis, the drug of choice will be your pyridostigmine, or in severe forms, you need to give steroids. Whereas in Lambert-Eaton myasthenic syndrome, the drug of choice will be 3,4-diaminopyrimidine. And what does this 3,4-diaminopyrimidine does? This 3,4-diaminopyrimidine, it will block the potassium channels within the motor units. Once you block the potassium channels, the cell will be in a state of depolarization. So there will be continuous release of the acetylcholine. Okay. So in the another important difference is in myasthenia gravis, at the level of synapse, the acetylcholine levels will be adequate. Whereas in Lambert-Eaton myasthenic syndrome, the acetylcholine levels at the synapse will be reduced. That's a very important difference between Lambert-Eaton and as well as the myasthenia gravis. So these are the neuromuscular junction disorders which we are done with. Okay, right. The next important topic for the quick revision is the brainstem stroke syndromes. Okay, so now, if you take this brainstem stroke syndromes, there is one important clue for all these brainstem stroke syndromes. So, what are all your brainstem structures? Midbrain, pons, and as well as the medulla oblongata. So, these three comes under your brainstem structures. Now, in case of brainstem stroke syndromes, you just remember an important rule that there will be ipsilateral cranial nerve involvement and there will be contralateral corticospinal tract involvement will be there. That is contralateral pyramidal tract involvement will be there. Like for example, you take midbrain stroke. Okay, in midbrain, what are the cranial nerves which are present within the midbrain? That is the cranial nerve 3 and 4. And exactly in between midbrain and as well as pons, you have even the fifth cranial nerve. And in pons, what are the cranial nerves that you have? 6, 7 and as well as 8. And medulla oblongata, you have 9, 10, 11 and 12. So now, if the history says that there is ipsilateral seventh nerve palsy and contralateral hemiparesis is there, that immediately should think that we should immediately think that the level of lesion is within the pons, and you need to be very much aware of the Pontine syndrome. Okay. Now, I'll just quickly recap what are your midbrain stroke syndromes, Pontine syndromes, and as well as the medulla oblongata syndromes. Okay, so you take the first one, that is the Weber syndrome. What exactly is your Weber syndrome? That is a midbrain stroke syndrome, right? Midbrain stroke syndrome. So when I'm using the word midbrain, right? When I'm using the word midbrain, Okay, so which particular structure should be affected, you should be very much aware of. So all of the following are true about Weber syndrome, except is the question, right? Except. So ipsilateral third nerve palsy, diplopia, contralateral hemiplegia, ipsilateral facial nerve palsy. Very simple, right? Once you know that Weber's is a midbrain, so in the midbrain you don't have the seventh nerve. So where will be your seventh nerve? That will be in the pons. So the answer is D. That is an incorrect statement. Now, what are all your midbrain stroke syndromes? At least you should know the names, right? So leave about the depth of the manifestations. At least you need to know the names of these midbrain stroke syndromes. What are those? Weber's, Benedict's, Claude's, Perinaud's, and North-Nagel syndrome. These five are your midbrain stroke syndromes, right? Weber, Benedict's, Claude's, Perinaud's, and North-Nagel syndrome. So these are your midbrain stroke syndromes. Okay. Now, what is that you should remember? Whenever you are using the word midbrain, there should be involvement of your third or fourth cranial nerve. Accordingly, manifestations should be there, and contralateral hemiparesis should be there, right? And these are all your midbrain stroke syndromes, right? What is very, very important for me that you should remember? At least names are very, very important, right? If the question examiner wants to frame the question very simple on the brainstem stroke syndrome, which among the following is not the midbrain syndromes, right? So in which one of the option will be your Quantine syndrome, right? Like Foville syndrome. Okay, so the answer will be Foville there. So the five syndromes, Weber's, Benedict's, Claude's, Perinaud's, and as well as North-Nagel syndrome will be your brainstem stroke syndrome. Now you see a question on the Benedict's. Benedict syndrome, all are true except contralateral tremors, third nerve palsy, involvement of penetrating branch of basilar artery, lesion at the level of the pons, which is the incorrect statement here. Just simple. This is one of the PYQ. Okay, this is one of the PYQ. Right now, the answer is very simple now. That is lesion at the level of the pons, because you know that midbrain stroke syndromes are like Weber's, Benedict's, Claude's, Perinaud's, and North-Nagel. Just by knowing that, you will be able to answer this question. Okay. Right. Now, after having said about the midbrain stroke syndromes, now let me discuss or let me tell you about the Pontine syndrome. Okay. So, what are all your Pontine syndromes? There are totally 4 Pontine syndromes, important ones. Okay. Like, I'll tell you what are all those. So, you see this question. The Millard-Gubler syndrome includes all of the following except fifth nerve palsy, sixth nerve palsy, seventh nerve palsy, the contralateral hemiparesis. Contralateral hemiparesis. Even this also you can answer it very comfortably and easily without any problem. What did I tell you? In Pontine syndromes, like you have definitely involvement of sixth and seventh nerve, and contralateral hemiparesis will be there. But where is your trigeminal nerve nucleus, right? It is starting in between your midbrain and pons. So the one which you can rule out and answer is the fifth nerve palsy, right? It is the fifth nerve palsy. So what are all your Pontine syndromes? There are totally 4 important Pontine syndromes. That includes your ventral Pontine syndrome, which is nothing but your Millard-Gubler syndrome, where there is involvement of your sixth and seventh nerve ipsilaterally, and contralateral corticospinal tract hemiparesis will be there, and it is the ventral Pontine syndrome. Then you have lower dorsal pontine and as well as the upper dorsal pontine. So what is this lower dorsal pontine and upper dorsal pontine? Lower dorsal pontine will be Foville syndrome, and upper dorsal pontine will be the Raymond-Seston syndrome. But what is very, very important in Pontine syndrome that you have to remember is the locked-in syndrome, right? It is locked-in syndrome. What is locked-in syndrome? It is bilateral ventral pontine syndrome. Okay, actually, like ventral pontine syndrome, like we have Millard-Gubler, but if it is bilateral ventral pontine lesions, right? If it is bilateral ventral pontine lesions, what is that? That is your locked-in syndrome. That is your locked-in syndrome. Now, what will be the features in case of the locked-in syndrome is everything is gone. In locked-in syndrome, everything is gone. Only the sensorium of the individual is being preserved. Why the sensorium or consciousness is being preserved? Because reticular formation is not damaged in case of locked-in syndrome. That is one thing. The another important thing that will be preserved in case of locked-in syndrome is, right, vertical eye movement will be preserved. Why? Because supranuclear oculomotor pathways are being preserved, because oculomotor nerve, it is present in your midbrain, so your oculomotor pathways are being preserved, so vertical eye movement will be preserved. Otherwise everything is lost in case of locked-in syndrome. That means quadriplegia will be there, the individual is unable to speak, and even the horizontal eye movement is also lost. Why horizontal eye movement is lost? Because sixth nerve palsy, and sixth nerve, where is there, where is it present? It is in the pons. Okay, so just remember the names of the 4 Pontine syndromes. Okay, So number one is your Millard-Gubler syndrome, which is a ventral pontine syndrome. Then lower dorsal pontine syndrome, it is your Foville syndrome. The upper dorsal pontine syndrome will be Raymond-Sisson syndrome. And finally, your bilateral ventral pontine lesion, that will be logged in syndrome. Okay, right. So we are done with the pontine syndromes. Now I'll just ask you a question. Please answer this. A 65-year-old diabetic woman develops weakness in the left side of the face, right? Weakness in the left side of the face. And the individual is having right arm and right leg weakness. She also has diplopia on left lateral gaze. What is the site of lesion in this individual? Right pons, left pons, right midbrain, left midbrain. So where exactly do you think is the problem in this patient? Yes, any one of you? Right. So the correct answer here will be yes, anyone? No, no, no. It is not A. It is left pons. It is not the right pons. It is left pons. What did I tell you? In case of brainstem, see, I have taught you the principle of brainstem stroke syndromes in the beginning of this brainstem discussion itself. What did I tell you? There will be ipsilateral cranial nerve pathology, contralateral corticospinal tract involvement will be there. This rule applies for all the brainstem stroke syndromes. Okay. Now, if you go to this particular question, which side facial weakness is there? Left side face is weak. That means your seventh nerve is gone on the left side. And diplopia on left lateral gaze. That means your left side abducens is gone. And contralateral hemiparesis, right upper limb and lower limb is weak. So the pathology will be in the left pons. Pathology will be in the left pons. It is not in the right pons. Okay. Then, so this is about your Quantine syndromes, right? So you repeat with me all the midbrain and as well as Quantine stroke syndromes, right? What are all the midbrain stroke syndromes? Weber's, Benedict's, Claude's, Perinaud's, Knock-Nagel. These are midbrain stroke syndromes. What are pontine syndromes? Like we have ventral pontine syndrome, that is Millard-Gubler. Bilateral ventral pontine lesion, that will be logged in syndrome. And dorsal pontine, again we classify that into lower dorsal and as well as the upper dorsal. Okay. So the upper dorsal pontine lesion will be Raymond-Sisson syndrome. Lower dorsal pontine will be the Foville syndrome. Okay. So this is very clear regarding the pontine syndromes. Now we'll move on to the discussion of the medullary stroke syndromes. Right. So medullary syndromes only we have two: lateral medullary syndrome, medial medullary syndrome. Right. Lateral medullary, medial medullary. Now this lateral medullary syndrome, this is also called as Wallenberg syndrome. Right. This is also called as the Wallenberg syndrome. Now, what is the vessel which is being affected in your lateral medullary syndrome? So you see this question. It is caused by thrombosis of which particular vessel? Right. Caused by which particular vessel? Right. So it is the vertebral artery. Very good, Monica. So it is the vertebral artery most commonly, followed by that involvement of pica, posterior inferior cerebellar artery. Okay. So these are all the PYQs which I am trying to discuss now. Now, in case of lateral medullary syndrome, what are the structures which are affected? Right. You see this question. Lateral medullary syndrome, which is also called Wallenberg syndrome, is characterized by all except giddiness, dysphagia, cross hemianesthesia. Horner syndrome is rare in this individual. Yes. So what do you think is the incorrect statement? Right. In case of Wallenberg's, let me tell you what will be the ipsilateral cranial nerves which are being affected. There will be 8th nerve involved, 9th nerve involved, 10th nerve involved, and contralateral, right? Contralateral corticospinal tract will be gone, right? And contralateral ascending tract, which particular ascending structure? That is spinothalamic tract is gone. These are the structures which are affected in lateral medullary syndrome. So you take this particular giddiness, that can be there because of the involvement of your vestibulocochlear nerve. Dysphagia, that will be there because of involvement of your 9th and 10th nerve, 10th cranial nerve. Cross hemianesthesia, that will be there because of the involvement of spinothalamic tract. And let me tell you, in lateral medullary syndrome, even your sympathetic outflow is also being affected, and thereby the individual will have Horner syndrome. Horner syndrome is not a rare manifestation in lateral medullary syndrome. It is very common in case of lateral medullary syndrome. Okay, so that's a very, very important point. Horner syndrome is seen, right? What are the components of your Horner syndrome? Ptosis, meiosis, enophthalmos, right? Anhydrosis and loss of ciliospinal reflex. Okay. And one more important question is, all of the following are the features of Wallenberg syndrome except ipsilateral loss of pain and temperature, ipsilateral loss of taste sensation, ipsilateral loss of posterior column sensation, ipsilateral involvement of the lower cranial nerve involvement. So what do you think is the incorrect statement here? Except, just now we have discussed the concept of your Wallenbergs and you should be able to answer this. Any one of you? Right. So, what did I tell you? It is contralateral or opposite spinothalamic tract is being affected. So, ipsilateral loss of pain and temperature will not be there in Wallenberg's. It is contralateral pain and temperature will be lost. Okay. And there will be ipsilateral loss of the taste sensation. Why there is ipsilateral loss of taste sensation? That is because of your ninth cranial nerve. That is your chorda tympani, which will bring the taste sensation from posterior 1/3 of the tongue. That will be the ipsilateral. And the another important structure which is being affected in Wallenberg's is ipsilateral dorsal columns. And because of the involvement of ipsilateral dorsal columns, okay, that is nothing but your ipsilateral posterior column sensations are being lost. That means there will be loss of your vibration sense, pressure sense, and as well as the fine touch. And there will be also ipsilateral involvement of the lower cranial nerves. So all are the features of Wallenberg syndrome except what? That is ipsilateral loss of pain and temperature will not be there, contralateral loss of pain and temperature will be there. And please remember one important point in it: lateral medullary syndrome, 12th cranial nerve is not affected. And where is that the 12th cranial nerve is being affected? That is in medial medullary syndrome. In medial medullary syndrome, which is also called Dejerine syndrome, there you have the involvement of the 12th cranial nerve. Along with that, there is also involvement of the corticospinal tract in case of the medial medullary syndrome. And what is the vessel that is being affected in case of medial medullary syndrome? That is the anterior spinal artery. Okay, so the anterior spinal artery is the vessel which is being affected in case of the medial medullary syndrome. And one important point you have to remember is that because of the involvement of the 12th cranial nerve, what will happen? There will be lower motor neuron paralysis of the tongue, and that lower motor neuron paralysis of the tongue will be on the ipsilateral side, right? And corticospinal tract is affected, so there will be contralateral hemiparesis will be there. Okay, so that is what is the features of your medial medullary syndrome. So with this we are done with the brainstem stroke syndromes. So just repeat with me, what are all your midbrain stroke syndromes? That is Weber's, Benedict's, Claude's, Perinaud's, North-Nagel. These are midbrain stroke syndromes. What are your Quantine syndromes? You have two ventral Quantine syndromes. What are those? One is your Miller-Gubler syndrome, and the other one is bilateral ventral pontine lesion will be there in case of the locked-in syndrome. And what are the dorsal pontine lesions? Lower dorsal, upper dorsal. Lower dorsal will be Fowell syndrome. Upper dorsal will be Raymond-Seston syndrome. Then you take medial medullary syndrome. Medial medullary syndrome, lateral medullary and medial medullary. Lateral medullary syndrome is called Wallenberg syndrome and medial medullary syndrome is called Dejerine syndrome. So with this, we are done with the brainstem stroke syndromes. Now, yeah, Mr. K, your dorsal column involvement, it can be there in both medial medullary and as well as lateral medullary. But in medial medullary, the dorsal column involvement is more predominant rather than lateral medullary. Lateral medullary, dorsal column involvement is rare or occasional. But in medial medullary, definitely dorsal column involvement will be there. Okay, right. Now, yes. Now, you see this question, that is the middle-aged male patient presents with worst headache of his life. What is the investigation of choice? Now what exactly is the diagnosis of this clinical scenario which has been given? That is the subarachnoid hemorrhage. And in subarachnoid hemorrhage, like, the investigation of choice will be the non-contrast CT. So we don't do this contrast enhanced CT scan. Why is that? When you give contrast, that particular contrast cannot identify the blood which is there within the sylvian fissure in subarachnoid hemorrhage. That is the reason why contrast enhanced CT is not the investigation which is being done. And MRI, it will take long time and this is an emergency, so MRI not preferable. Now lumbar puncture. When will you do lumbar puncture in patients with subarachnoid hemorrhage? Now, in patients with subarachnoid hemorrhage, the hemorrhage can be identified immediately once you do a non-contrast CT. But if you do this non-contrast CT in case of subarachnoid hemorrhage beyond 12 hours, then subarachnoid hemorrhage may not be seen. You can miss that, right? So the CT may appear normal. When CT scan is appearing normal, but you have a strong suspicion of subarachnoid hemorrhage, then you need to do lumbar puncture. So what will the lumbar puncture show? All that we will discuss now. Okay. So you take this subarachnoid hemorrhage. What is the most common cause of subarachnoid hemorrhage? That is the head trauma. And what is the second most common cause of subarachnoid hemorrhage? That will be the rupture of the berry aneurysm, right? And what is the most common site of the berry aneurysm? The most common site of berry aneurysm is at the junction of, right, at the junction of anterior communicating artery with the anterior cerebral artery, right? Junction of anterior communicating artery with the anterior cerebral artery. Okay, right. So that will be right. That will be the second most common cause. Now, what is the investigation of choice? We have discussed non-contrast CT scan, and CSF will show you the presence of the xanthochromia, right? Where you have yellowish orange CSF. Why do you get that yellowish orange CSF? That is, the hemoglobin which is present in the RBC will mix up with the CSF, and thereby you get this yellowish orange CSF. Okay, and that is what is called xanthochromia. Next. Now, what is the purpose of doing the CT cerebral angiogram? The purpose of doing CT cerebral angiogram, that is mainly to localize the berry aneurysm. And depending upon that, you can plan the treatment, that is your coiling, or the treatment can be planned by doing your CT cerebral angiogram. Okay. Then next is, yes, so this is a non-contrast CT where you can observe very clearly the hyperdense structures, right? Hyperdense structure in the sylvian fissure, and that is what is nothing but your subarachnoid hemorrhage. Okay. Now, the very, very important is, okay, is there any role of transcranial Doppler? Right, transcranial Doppler. Yes, there is role of the transcranial Doppler. What is the purpose of doing this transcranial Doppler? The purpose of doing this transcranial Doppler is to look for the development of any compensatory cerebral vasospasm. If there is compensatory cerebral vasospasm, the individual will develop ischemia and there will be cerebral infarction. So that for that purpose we need to do the transcranial Doppler. Now, what is the treatment in this individual? It is the supportive treatment. Only when there is a midline shift, then you need to do the decompressive surgery, right? Then you need to do decompressive surgery, that is craniotomy. And once, if the transcranial Doppler shows vasospasm, then you need to give calcium channel blocker. That is, to prevent the vasospasm, we need to give this calcium channel blocker, that is nimodipine should be given. So this is about your subarachnoid hemorrhage, which can present in the form of the worst headache in the life, right? And the CT will show you the presence of hemorrhage within the sylvian fissure, right? Now, after your subarachnoid hemorrhage, let me move on to the discussion of the cerebrovascular accidents. So in the cerebrovascular accidents, what is the most common cause of cerebrovascular accident? That is the embolism. So embolic stroke, that is the most common cause for cerebrovascular accident. Actually, there are three important causes. One is your embolism, second is thrombosis, and third one is the hemorrhage. But the most common among all these will be your embolism, right? Which will cause the ischemic stroke. And in the CT, you have the presence of a hypodense lesion. Okay, right. Now you see this question. A middle-aged patient presents with history of left-sided weakness for 2 days. Currently, the patient is extremely drowsy and underwent a non-contrast CT scan. Which of the following is the best treatment for this patient? And this is one of the PYQ. The options are aspirin, clopidogrel, mechanical thrombectomy, mannitol, decompressive surgery. Right? So, what is the duration of this particular weakness? The duration of this particular weakness is almost 2 days. Now, what is that you will be doing in this individual? So, if you clearly see the CT scan in a zoomed way, you can see the ventricle is being compressed, and you can see that there is a minimal midline shift which is being present. So, whenever there is a midline shift, that is an indication for doing the decompressive surgery, which is nothing but your craniotomy. And what exactly you are seeing here? It is a large hypodense lesion, right? It is the large hypodense lesion, right? And where exactly is this particular large hypodense lesion? It is present in, okay, so it is the left MCA. You have this large hypodense lesion. Now, why don't you do mechanical thrombectomy? Remember, you can do mechanical thrombectomy if the patient presents to you within 8 hours. But what is the duration of the weakness? Almost 2 days. So there is no role of mechanical thrombectomy in this patient, right? There is no role of mechanical thrombectomy. And what about mannitol? Yes, mannitol is also useful, but the question asked is the best treatment. That will be your decompressive surgery, that is craniotomy. Why? Because there is a midline shift in this particular patient. Now, what about your antiplatelets? Like antiplatelets, that is aspirin or clopidogrel, will be useful in case of the ischemic stroke, but not in this scenario where there is a midline shift. Okay, so this is one of the question or the management protocol in case of the ischemic stroke. And one more very simple and easy question which was asked PYQ. Right. See, I'll just tell you one important point for you. Right. So everyone of you are appearing for the exam. Right. And what is that particular FOMO which gets created among you is whether the question that comes in the exam will be the same thing what I have read, or it will be beyond my expectation, right? So how many of you have this particular FOMO, that the question which comes, whether that will be the question which I read or beyond what I have read? That is the common thought process which will be going on for each and every student. Just remember that if you have put your 100% effort in your preparation, that is done and enough, definitely the question will come in the exam whatever you have read. And don't be under the assumption that some difficult high level questions may come. It is not always like that. 80% or 70% of the question paper may be tough. At least 20 to 30% of the questions will be PYQs related to questions or simple questions also. Like one among that is like this. Okay. Now, yes, what is the window period for thrombolysis in a stroke patient? Yes, Gokul Krishnan, you have you have accepted that, but many people have the same thing. Okay, right. So, what is the window period for thrombolysis? The window period for thrombolysis is right. So, yes, some of you are accepting that particular FOMO. Right. So, the window period for thrombolysis is the 4.5 hours. Now, what is that particular thrombolytic agent which we use? That is the tissue plasminogen activator. That is what is the thrombolytic agent that we will be using. Now, what is the indication for thrombolysis? Number one, the window period of that ischemic stroke should be less than 4.5 hours. Next, age of the patient should be more than, sorry, age of the patient should be more than 18 years. And third important thing is the CT scan, right? CT scan showing no edema, right? CT scan showing no edema of more than one third of MCA territory, right? And if CT scan shows edema of more than one third, then don't do thrombolysis, right? That ischemia can turn into hemorrhage. And if CT scan shows no edema more than one third of MCA territory, then it's an indication for thrombolysis. Okay, right. So this is about the story related to your ischemic stroke. Now, one more important PYQ, right? One of the other important PYQ is, which of the following complication of the stroke need not be treated? Fever, spasticity, neglect, dysphagia. Which of that need not be treated? Any one of you? Right. So the one that need not be treated is the neglect, right? And you take, what is this neglect? That is nothing but your hemi neglect. So hemi neglect, or the another terminology for this particular hemi neglect is spatial agnosia. When will the individual develops this nature of hemi neglect or spatial agnosia is that where the presence of neglect implies the blockade of, right, it implies the blockade of the inferior division, right, inferior division of the middle cerebral artery. That is what the neglect means. Okay, right? And what does that, and where exactly will be the site of lesion for the development of neglect? The site of lesion will be in the non-dominant hemisphere, and that too within the parietal lobe. Non-dominant parietal lobe, that will be the site of lesion for the development of the neglect. And what exactly happens is, these particular patients, they feel that they feel that the affected limb do not belong to them. That is what is your neglect. And see, you just give an image to this patient and he will be able to draw only half of that image. The remaining half he feels that it does not exist at all. It does not exist at all. Okay, That is what is your neglect. So, and if this particular patient develops neglect, that need not be treated, right? Whereas fever, it should be treated because that will further precipitate the manifestations of the stroke. Spasticity, yes, it has to be treated by giving baclofen. Otherwise, the individual will have, the muscle weakness, because there will be a prolonged prolonged atrophy will be there. Disuse atrophy will be there, and spasticity is commonly seen whenever there is upper motor neuron involvement. And dysphagia also have to be treated, otherwise there can be regurgitation of the food. And the one which need not be treated as an emergency basis is the neglect, and neglect will appear whenever there is involvement of the inferior division of the MCA, and that too non-dominant parietal lobe involvement, right? So after having discussed this, we'll move on to the quick revision of the next topic, that is aphasia. So that was the quick revision of the cerebrovascular accident. Now let me take up the discussion of this aphasia. What exactly is your aphasia? Where there is loss of speech. Which of the following is not a feature of the right MCA territory infarct? Aphasia, hemiparesis, facial weakness, dysarthria. Remember, whenever there is right MCA territory involvement, aphasia will not be there. In order to develop aphasia, it should be left MCA territory involvement. Why? Because the speech areas, that is Wernicke's area and as well as Broca's area, are present within the left cerebral hemisphere, not in the right cerebral hemisphere. So it should be the left MCA involvement for the development of the aphasia. Now you have three important forms of aphasia: Broca's aphasia, Wernicke's aphasia, conduction aphasia, and some rare forms like global aphasia. Now you take this Broca's aphasia. So Broca's aphasia is what exactly the type of aphasia? Remember, Broca's aphasia, they will have decreased fluency. So Broca's aphasia, it is a non-fluent aphasia, right? It is a non-fluent aphasia. And this Broca's aphasia, it is what? It is the motor aphasia, right? And these patients, they will have the comprehension being spared, right? The comprehension being spared in case of the Broca's aphasia. And what is another problem in Broca's? There will be impaired repetition, right? There will be impaired repetition. That is what you will have in Broca's aphasia. So remember, in Broca's aphasia, it is there will be decreased fluency, comprehension will be spared, they will have impaired repetition, and it is a motor aphasia, right? Then you take the Wernicke's aphasia. Wernicke's aphasia, it is the sensory aphasia, right? It is a sensory aphasia. And in case of the Wernicke's aphasia, what happens is the comprehension is being lost, right? Comprehension is being lost in case of Wernicke's aphasia. And in case of Wernicke's aphasia, remember, the fluency of the speech will be preserved. And in these patients, they will also have impaired repetition. So impaired repetition is seen in all the forms of aphasia, right? All the forms of aphasia. So these are the features of the Wernicke's aphasia. And in these patients with Wernicke's aphasia, they will also have neologisms. Neologisms means what? The new words formation. That means they'll have empty, meaningless, and nonsensical errors, right? Empty, meaningless, and full of nonsensical paraphasic errors will be there in case of the Wernicke's aphasia. Then you have the conduction aphasia. So what is this conduction aphasia? Conduction aphasia is that the connecting structure between the Broca's area and Wernicke's area is lost. And what is that connecting structure? That is arcuate fibers. So arcuate fibers are damaged. So once your arcuate fibers are damaged, these patients, they will have impaired repetition, right? They will have impaired repetition. Then what are the other problems in conduct? Only impaired repetition, that's all. The comprehension will be spared, fluency will be spared, but the only problem is your impaired repetition. So your conduction aphasia and as well as Wernicke's aphasia, they come under fluent aphasias, right? Conduction aphasia and Wernicke's aphasia, they are the fluent aphasias, whereas Broca's aphasia, that will be a non-fluent aphasia, right? So that is about your the aphasia. One more question. Aphasia which affects the arcuate fibers is called, just now we have discussed, that is nothing but your conduction aphasia, right? What is anomic aphasia? Anomic aphasia, usually you get this in case of the metabolic encephalopathies, like where the individual is unable to name the object, right? So that is called the anomic aphasia. And one more question you see here, the fluent aphasia with preserved comprehension and impaired repetition. So comprehension preserved, fluency preserved, but there is only impaired repetition. So what exactly is this will be? This is nothing but your conduction aphasia, right? This is nothing but your conduction aphasia, right? Next. Now, so that was about the topic related to the aphasia. Quick revision. Now, once we are done with the aphasias, we'll move on to the spinal cord lesions. So in the spinal cord lesion, I'll discuss two important conditions: Brown-Sequard syndrome, and the other one is the conus medullaris and as well as cauda equina. These are the two conditions. Let me discuss. So what exactly is your Brown-Sequard syndrome? Brown-Sequard syndrome is nothing but your hemisection of the spinal cord. So there is a half of the spinal cord which is being cut. So in Brown-Sequard syndrome, what will be the features? They will have sensory manifestations and they will also have the motor manifestations, right? Sensory manifestations and as well as the motor manifestation. And what will be that? Let me discuss that. Okay, so the question is, the following are the components of Brown-Sequard syndrome except. The options are ipsilateral extensor plantar response, second option ipsilateral pyramidal tract involvement, contralateral spinothalamic tract involvement, contralateral posterior column involvement. That means the question is like, which is the incorrect statement that you will have in Brown-Sequard syndrome? Yes, anyone want to make an attempt of this question? Incorrect statement, right? Very good, Himanshu. So contralateral posterior column involvement will not be there. So please remember, in Brown-Sequard syndrome, how do we classify the lesions into? We classify the lesions. Okay, so one. Yes. So the symptomatology, we classify that into below the site of lesion, what will be the manifestations? At the site of lesion at the spinal cord, what will be the manifestations? You take below the site of lesion. So below the site of lesion, you have motor changes and as well as the sensory changes. Now below the site of lesion, what will be the motor changes? The motor changes that you will have is the pyramidal tract involvement. So always remember one important concept in your spinal cord lesions. What is that important concept that you need to remember in spinal cord lesions? At the site of lesion, the motor manifestation will be lower motor neuron type of paralysis. Below the site of lesion, it is always upper motor neuron type of paralysis. So below the site of lesion, you will have pyramidal tract involvement and that too ipsilateral. Then what will be the sensory changes? Sensory changes, you need to know what are the ipsilateral gone, what is the contralateral gone. Ipsilateral gone will be your dorsal columns, right? Because dorsal columns, they don't cross at the level of spinal cord. Dorsal columns, they cross at the level of your brainstem. So ipsilateral dorsal column gone. Contralateral spinothalamic tract is gone. Why? Because your spinothalamic tract is crossing at the same level to the opposite half. So contralateral spinothalamic tract structures will be lost. That will be the below the site of lesion. Now, at the site of lesion, what did I tell you about the motor? Motor will be lower motor neuron paralysis. And what will be the sensory changes? There will be ipsilateral dermatomal pattern is being lost. Okay. So going back to the question now, right? Going back to the question now. So ipsilateral extensor, ipsilateral pyramidal tract is nothing but your corticospinal tract involvement. Contralateral spinothalamic tract involvement, correct statement. Contralateral posterior column will not be there. It will be ipsilateral posterior column involvement will be there in patients with the Brown-Sequard syndrome. Now, you see the one more question. Type of sensation lost on same side in Brown-Sequard syndrome. Pain, touch, proprioception, temperature. Now we have discussed which particular tracts are gone on the same side. We have discussed. Now you should be able to answer this question. Any one of you, please. Pain, touch, proprioception, temperature. Right, very good, Monica. So it is the proprioception which is being lost. Why is that proprioception which is being lost here on the because of the involvement of dorsal column? Whereas your pain, touch, temperature, they are being carried by spinothalamic tract. That will be the contralateral sensation that is being lost. Okay, so that is quick recap of your Brown-Sequard syndrome. And one more PYQ on the Brown-Sequard syndrome. We'll discuss this and then we'll move on to the next topic. That is, a ventrilateral cordotomy is performed to produce the pain relief from the right leg. So where do you want the pain relief from? The pain relief from the right leg. It is effective because it interrupts the left dorsal column, left lateral spinothalamic tract, right lateral spinothalamic tract, right corticospinal tract. So which particular structure you want to see that it is being cut, so that you want the pain relief from the right leg. So if you want to have a pain relief from the right leg, please remember it is your left lateral spinothalamic tract should have been cut, because your left lateral spinothalamic tract, you know, on the left, what actually is your left lateral spinothalamic tract? It is nothing but the one which is coming from right. The sensation which is being brought is from right. Okay, so once you cut this left lateral spinothalamic tract, the sensations on the right leg will be lost. Okay, so the correct answer is B. So that is about your what? Your Brown-Sequard syndrome, which is nothing but hemisection of the spinal cord. Now let us move on to the next topic, that is conus medullaris and as well as the cauda equina. So if you take this conus medullaris and cauda equina, these are the pathologies where there is involvement of lower part of the spinal cord. What exactly is your conus medullaris? Your conus medullaris, it is nothing but the condensed structure of the lower part of the spinal cord. That means the sacral part of the spinal cord is being completely condensed. That will form the conus medullaris. Then what is your cauda equina? Cauda equina, it is nothing but your lumbar and as well as the sacral spinal nerves. Right, that includes lumbar and sacral spinal nerves. That will be your cauda equina. So what will be lumbar? L1 to L5. What will be sacral? S1 to S5. Okay, so that will be your cauda equina involvement. Conus medullaris is what? Where there is involvement of your sacrum. Now if you take the clinical manifestations in these individuals, in conus medullaris, the presentation will be sudden and as well as bilateral. The manifestation will be sudden and as well as bilateral. Okay, why is that? Because it is the condensed structure which is being affected in conus medullaris, but whereas cauda equina, it is a bunch of the nerves. So the presentation will not be sudden in onset. The presentation will be gradual and unilateral. Right, the presentation will be gradual and the unilateral. That is what you will have in case of cauda equina. Now if you take the deep tendon reflexes, conus medullaris, which particular structure is gone? Sacral part of the spinal cord is gone. So that means in case of your conus medullaris, which deep tendon reflex is lost? That is only the ankle jerk that will be absent, whereas knee jerk will be present in case of conus medullaris. Whereas you take in cauda equina, your lumbar and as well as sacral spinal nerves are gone. That means your knee jerk and as well as the ankle jerk, both of them are lost. Because what is the root value for your knee jerk? That will be your L3, L4, and root value for ankle jerk, that will be L5, S1. Okay, but predominantly S1. So because in cauda equina, your lumbar and sacral spinal nerves are lost, so both the knee jerk and as well as the ankle jerk is being lost. Then what will be the clinical presentation? See, in conus medullaris, the patient will present with low back pain because of the injury to the sacral part of the spinal cord. Whereas in cauda equina, it is the spinal nerve roots which are affected. So the presentation will be classically radicular pain. Right, the presentation will be classically radicular pain, which is also called the root pain. Right, so the pain, it starts at the level of the spinal cord and it radiates down. That is what is called the radicular pain or the root pain. Okay, next, and the another important point is the motor involvement. So motor weakness in case of conus medullaris, it will be typically symmetrical, whereas in cauda equina, the motor weakness will be asymmetrical and it will be mainly lower motor neuron type of paralysis. So here you get element type of paralysis because it is the roots which are getting affected, that is anterior horn cell. But whereas here you have the upper motor neuron manifestations along with the lower motor neuron manifestations, where in case of conus medullaris. So these are the differences between conus and as well as the cauda equina. So what is very important thing that you need to remember? In case of conus, it is the sacral part of the spinal cord commonly affected, whereas in cauda equina, it is both lumbar and as well as sacral spinal nerves which are being affected. Conus, the onset is sudden in onset, bilateral. Cauda equina, it is gradual in onset and as well as unilateral. And in conus, knee jerk is preserved and ankle jerk is lost, whereas in cauda equina, both the reflexes are being lost. And the presentation will be low back pain in case of conus, whereas in cauda equina, it is radicular pain or the root pain that will be there in case of the cauda equina. And motor presentation, it is like symmetrical weakness that you will have in conus, and mainly it is upper motor neuron type of weakness. Whereas in case of cauda equina, it is asymmetric, areflexic paraplegia will be there. Okay, areflexic, that means lower motor neuron paralysis will be there. So that is about the two important spinal cord involvement. Next, we'll move on to the disorders of the cranial nerves. Right. So within the disorders of the cranial nerve, I'll discuss the two important cranial nerves. So what is that? You see the clinical presentation. A patient presents with recurrent episodes of sharp pain over the right cheek, and that is precipitated on chewing. Between the attack, the patient is otherwise normal. The most probable diagnosis is preherpetic neuralgia, trigeminal neuralgia, mumps, and as well as the thalamic syndrome. Right? Thalamic syndrome. Okay. So what do you think is the correct statement here? That is the trigeminal neuralgia. So whatever the clinical picture which has been given to you, it is in favor of the trigeminal neuralgia. See, in trigeminal neuralgia, what will you classical clinical presentation? The individual will have intense, sharp, superficial, or stabbing pain. Right? Intense, sharp, superficial, or stabbing pain will be there in the distribution of the fifth cranial nerve. Right, in the distribution of the fifth cranial nerve, right? And right side is most commonly affected than compared to that of the left side. Okay, and the next is what will be the duration of this particular pain? The duration of this particular pain will be there only for few seconds, and the onset will be paroxysmal. That means the pain will be sudden in onset, and along with the pain there can be also the facial muscle spasms, and because there is spasms, this we call it as the tic douloureux. Right, it is called tic douloureux. Okay, now this trigeminal nerve, you have three important divisions. That is ophthalmic division is there, right? Then mandibular division is there, then maxillary division is there. Now, in which particular division the features of the trigeminal neuralgia is most commonly seen? Let me tell you, the features of trigeminal neuralgia is most commonly seen in the mandibular division rather than the other divisions. And which side most commonly affected? Right side. Then compared to the left side. It is mostly unilateral. Occasionally it is bilateral. And these patients, they also have the autonomic symptoms, right? Autonomic symptoms, and these particular autonomic symptoms are mainly present within the ophthalmic division, right? And what is that ophthalmic division? That is nothing but your 5-1 division. And what will be that autonomic symptoms? Lacrimation, conjunctival injection, that is redness, and there will be rhinorrhea, that is discharge from the nose. So these will be the autonomic symptoms in case of trigeminal neuralgia. And what is the drug of choice in trigeminal? Okay, you should know the triggering factors. Remember, what are the triggering factors for trigeminal neuralgia is like even light touch in that particular area, smiling, grimacing, exposure to cold air, shaving, brushing, right? Eating. These are all the eating in the sense chewing. These are all the precipitating factors for the trigeminal neuralgia. Now, you should know what is the drug of choice. Drug of choice will be your carbamazepine. And if the patient does not respond to carbamazepine, then we give the alternative drugs, that is oxcarbamazepine, or even we can also give the baclofen. The other drugs can be given. And if the medical management is not enough, then we do the surgical treatment. What is that surgical treatment? See, most commonly the etiopathogenesis is trigeminal nerve root compression. So you need to do decompressive surgery or rhizotomy should be done. So that is what is the treatment for trigeminal neuralgia if the individual is refractory to medical management. Then we will move on to the discussion of the facial nerve involvement, right? Facial nerve involvement. Okay, now see, in this, what is the most common cause of the facial nerve palsy? That is Bell's palsy, herpes infection, Ramsay-Hunt syndrome, acoustic neuroma. What do you think is the most common cause of the facial nerve palsy? Please remember, the most common cause of the facial palsy, yeah, yes, Pushpendra, even your gabapentin can be given. They are all the medications which are given later when the individual is like refractory to carbamazepine. Okay? Right. Now, the most common cause of the facial nerve palsy will be your Bell's palsy. Now, what are all the various etiologies causing facial nerve palsy? Right. You have a mnemonic, that is B rash. What does this B stands for? That is Bell's palsy. Right. R stands for your Ramsay-Hunt syndrome. Right. Ramsay-Hunt syndrome is nothing but herpes zoster infection of your geniculate ganglia. Then A stands for the acoustic neuroma. S stands for sarcoidosis. And another H stands for the herpes infection. Another H will be herpes infection. And R, you have two conditions, Ramsay Hunt, and the other condition is Rosenthal-Melkersen syndrome. Rosenthal-Melkerson syndrome. These are all the causes of the facial nerve palsy. Now, let me just quickly tell you about what will be the features of upper motor neuron paralysis of the seventh nerve. What will be the features of lower motor neuron paralysis of the facial nerve? Yes, anyone of you? True regarding the upper motor neuron paralysis of the seventh cranial nerve. What is the true statement? So please remember, in case of upper motor neuron paralysis, it is the contralateral upper half will be spared, and it is the contralateral lower half of the face there will be paresis. Right? Contralateral, sorry, lower half of the face you will have paresis. That is what is your the upper motor neuron paralysis. Whereas you take in case of the lower motor neuron paralysis. In case of lower motor neuron paralysis, actually, yes. Most common cause is idiopathic. For Bell's palsy, what is the most common cause then? The most common cause of your Bell's palsy is idiopathic. We don't know what exactly is the cause for your Bell's palsy, right? Okay. Now, right now, so you take in case of the lower motor neuron paralysis, it is ipsilateral half of the face which is being paralyzed. Right, ipsilateral half of the face. So you can see the entire half of the face which is being paralyzed. So there are no folds over the forehead. The individual is unable to close the eye, and there is no nasolabial fold. Right, so these are the features of the lower motor neuron paralysis. So please remember, upper motor neuron paralysis, contralateral lower half paralysis will be there, whereas lower motor neuron paralysis, the ipsilateral half of the face will be paralyzed. Right, next, now in case of lower motor neuron paralysis, what is the true statement? Cornea should be protected. Bilateral paralysis is seen in Melkerson-Rosenthal syndrome. Unilateral paralysis in Mobius. Prognosis affected before the repeated electrical stimulation. Yes, any one of you? Right. Now let me tell you the correct statement. So the correct statement is the cornea should be protected. Why? Because the patient is unable to close the eye in case of lower motor neuron paralysis, right? Because the orbicularis oculi is paralyzed. So once your orbicularis oculi is being paralyzed, the individual is unable to close the eye. So the cornea should be protected, right? Now, you take the other options. You take this Melkerson-Rosenthal syndrome. It is not bilateral. It is mostly unilateral syndrome that is being seen. And what about your Mobius syndrome? Mobius syndrome, it is usually bilateral. And what exactly is your Mobius syndrome? Mobius syndrome, it is caused by the absence or underdevelopment of 6th and 7th cranial nerve nuclei. Right, 6th and 7th cranial nerve nuclei are being absent. That is what is your Mobius syndrome, and that is usually bilateral. Right, so these patients with Mobius, they'll have weakness of paralysis of the facial muscles. Right, and prognosis in case of LMN palsy, that is Bell's palsy, the prognosis is good in these individuals with the LMN palsy, right? Now, if you take about the Melkerson-Rosenthal syndrome, what did I tell you? Melkerson-Rosenthal syndrome, it is unilateral involvement, and there are three important. There is a triad in Melkerson-Rosenthal syndrome, and Melkerson-Rosenthal syndrome is one of the very important PYQ, right? So, in these patients with Melkerson-Rosenthal, there will be lower motor neuron paralysis of the facial nerve. Then there will be the swollen lip, and the tongue, how it will be? It will be the fissured tongue, right? The tongue will be the fissured tongue. That is what you will see in case of the Rosenthal-Melkerson syndrome, right? So this is about the story related to your seventh nerve. Now, after having discussed about the seventh story, next we'll move on to the next important topic, that is the differential diagnosis of the headache. So if you see this important question, what do you think is the most common cause of the headache? That will be the tension headache. Tension headache is what? It's a primary headache. What are all the causes for primary headache? Tension headache is the most common. Followed by tension headache, the next most common cause for primary headache is your migraine. Then what are the other causes for primary headache? That is your tension headache, migraine, then exertional headache, and even cluster headache. That is also primary headache. Then what is the most common cause for secondary headache? The most common cause for secondary headache will be systemic infections. That is the most common cause for the secondary headache, right? Then the next important point is, right, most common cause of headache will be what? That will be the tension headache. Most common type of secondary headache will be the infections. Most common cause of headache in females will be tension headache. And most common cause of headache in males, that will be also tension headache. If females have tension, definitely males also will have tension, right? So even in males, the tension headache is the most common. And most common cause of the frontal headache is also the tension headache. That is also the tension headache. Now let us discuss about the individual forms of the headache now. So the first important thing that you need to know is about the migraine. You need to know about is the migraine. So what is the mnemonic for the migraine? That is pound. Pound is the mnemonic. What is this pound stands for? P. So P stands for pulsating in nature. What is O stands for 1 day duration. The duration of the headache is like 4 to 72 hours. On an average, we take 24 hours. U stands for unilateral. N stands for there will be nausea in these patients with migraine. D stands for it is disabling in character. D stands for disabling in character. So out of these five, at least four are there, then we can consider it as the migraine, right? And now we have another terminology called status migrainosus. Status migrainosus is that if the duration of the migraine is more than 72 hours, then we call it as the status migrainosus. And we have two important forms of migraine. What are those two important forms of migraine? That is migraine with aura and then migraine without aura. Between these two, which is more common? Migraine with aura, this is the classical migraine, whereas migraine without aura is a common migraine. So migraine without aura is more common, right? Whereas migraine with aura, if you take, what is the most common form of aura? The most common form of aura will be the visual aura. Now, apart from this, you have other forms of migraine as well. That is retinal migraine, basilar migraine, and hemiplegic migraine. So, what do you think is the retinal migraine? See, retinal migraine is nothing but where the individual, along with the migraine, the patient will also have the blindness. That will be transient monocular blindness will be there. And that is mainly due to the involvement of the thrombosis of retinal artery. Basilar migraine is that along with migraine, the patient will have prominent brainstem strokes, brainstem symptoms. What will be that brainstem symptoms? That is vertigo, staggering, incoordination, dysarthria. So that will be your brainstem symptoms. Hemiplegic migraine, it is autosomal dominant type of inheritance. Along with migraine, the individual will have the unilateral hemiparesis. That will be your migraine. Now, what is the treatment for migraine? Please remember, in case of mild to moderate forms of migraine, in case of mild to moderate attack, we give the paracetamol. That is your NSAIDs. I mean to say NSAIDs. Whereas in severe form of migraine, that is your sumatriptan. In severe form of migraine, you need to give sumatriptan. That's a very, very important point that you need to remember. And for status migrainosus, what is the drug of choice? For status migrainosus, the drug of choice will be prochlorperazine. The drug of choice will be prochlorperazine. Then you need to know what are the drugs which are given for prophylaxis. Remember, the drugs which are given for prophylaxis in case of migraine, the first line drugs will be the beta blockers. Apart from the beta blockers, the other important drugs are like valproic acid, then we have topiramate, right? Then we have topiramate, and we have few more drugs, that is calcium channel blockers. What are these calcium channel blockers? These calcium channel blockers are the flunarizine. Calcium channel blockers are flunarizine or even the verapamil. These can be given as the prophylactic drugs, and we have some recently added monoclonal antibodies also, which can be given for the prophylaxis of the migraine. Okay, so with this we are done with the migraine. Just take a 2 minutes break. There is some technical issue. I'll just be back in 2 minutes. Okay, Venkat, stop. Okay, now. Right. So now, so these are all the drugs which are given for the prophylaxis. That is beta blockers, valproate, and as well as the topiramate. And the recently added drugs are the monoclonal antibodies. That is the erinumab, then galcinizumab, then freminizumab. Then we have the eptinizumab. Then we also give the botulinum toxin, but you have to remember that this particular botulinum toxin, it is mainly used for chronic migraine, but not for the episodic migraine. So this is about the treatment of the migraine. Now you take the next important clinical scenario. That is a 45-year-old man presents with the daily headache, right? Daily headache. And he describes 2 attacks per day over the past 3 weeks. Each attack lasts about an hour and awakens the patient from sleep. The patient has noted associated tearing and reddening of his right eye as well as the nasal stuffiness. The pain is deep, excruciating, and limited to right side of the head. The neurological examination is non-focal, the most likely diagnosis. So you take the pattern of the headache, it is the clustering pattern and commonly seen in males. And the headache is so severe that the individual is awakening from the sleep. And there is also reddening and tearing from the eye. So what is all this suggestive of? This is all suggestive of your right. Okay, so this is all being suggestive of the cluster headache. Now let me tell you some important points related to the cluster headache. So what will be the presentation in cluster headache is mostly it is unilateral and the headache will be periorbital in localization and the pain is very intense and non-throbbing and explosive in nature. Whereas migraine, it was throbbing in character, whereas here it is non-throbbing in character. And the duration of this particular headache will be less than 3 hours. Okay. Now, what is the treatment in these individuals? Please remember, in case of acute cluster headache, the first line treatment will be the high flow oxygen, that is 12 to 15 liters per minute you have to give. And if the high flow oxygen is not there in your option, the next important drug of choice will be sumatriptan injection. The other alternative drugs are gabapentin or pregabalin. And in prophylaxis, again, the drug of choice will be verapamil, which is nothing but your calcium channel blocker. Okay, so that is about your cluster headache. So you have to remember that the episodes will appear in clusters. Now, the next important clinical scenario is a woman has a bilateral headache that worsens with emotional stress and she has 2 children, both doing badly in the school. What is the diagnosis? The options are migraine, cluster headache, tension headache, and as well as trigeminal neuralgia. So this is the point suggestive of the tension headache, right? So tension headache, it is usually bilateral, right? And the duration is being non-specific and it is being reduced either by taking simple rest or the NSAID, that is paracetamol. That is what is your tension headache. Now, what are the other forms of headache? See, this particular table is very, very important. So cluster headache already we have discussed. Right. So cluster headache already we have discussed, like what will be that stabbing in character. Then the pain will be in the periorbital area or in the temple area, right? The frequency will be around 3 to 5 per day. The duration will be less than 3 hours. Autonomic symptoms will be in the form of tearing and reddening of the eye. And what is the active treatment in cluster headache? That is oxygen inhalation, sumatriptan injection and verapamil supplementation. That is prophylaxis. But whereas you take SUNC, what exactly is SUNC? SUNC stands for short lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing. So the character of the headache is same, that is burning or stabbing in character. But in case of SUNC, what is the different from the cluster headache is the episodes. The number of episodes should be more than 20 per day for the diagnosis of the SUNC. And the duration. See, the cluster headache, it will be there for up to hours, less than 3 hours. But whereas this for only seconds, that is 5 to 240 seconds, and autonomic symptoms will be there. But in SUNC, what is the treatment? SUNC, the treatment is lignocaine, and prophylactic drug will be lamotrigine or gabapentin will be given. And one more important condition is paroxysmal hemicrania. In paroxysmal hemicrania, the character of the headache is throbbing, whereas in cluster headache, it is non-throbbing, it is stabbing, right? Whereas paroxysmal hemicrania, it is like the throbbing type of headache. The pain will be orbital or in the temple region. And what will be the number of attacks per day? The number of attacks per day should be more than 5 and the duration will be around 2 to 30 minutes. So usually in the question they give you around 15 to 20 minutes and autonomic manifestations will be there. And what is the drug of choice in case of paroxysmal hemicrania will be the indomethacin. So these are the various forms of headache, and this is the differential diagnosis for your headache. Okay. Now, once we are done with the topic of headache, the next important topic is the Parkinsonism. So, Parkinsonism, we have two forms, primary Parkinsonism and as well as secondary Parkinsonism. So, what do you understand by the word primary Parkinsonism? That is mainly due to mutation of a gene, that is PARK gene, which is present on chromosome 1. Then what is secondary Parkinsonism? You have an underlying etiologies. These are all the underlying etiologies, out of which what is very important for you to remember is the drugs. What are these drugs? These drugs include reserpine, phenothiazines, butorphanol, and alpha-methyl dopa, and as well as metoclopramide. These are all the drugs which can decrease the dopamine levels, and that makes the individual to develop the Parkinsonism. And you have many other conditions which I have already discussed, which I have given you in the slide. But among all these, the drugs is very, very important, right? Now, what are the cardinal manifestations of the Parkinsonism? So, the cardinal manifestations, you can just remember this mnemonic, that is trap. What is this particular trap? That is tremors, rigidity, akinesia, and as well as the Parkinsonism. So, these are the cardinal manifestations. But if the question is asked, what is the earliest manifestation of Parkinsonism? That should be, the answer should be constipation. Followed by that, you have the other manifestations in the form of anosmia and all. But the earliest manifestation of Parkinsonism will be constipation. And next is this particular trap you need to remember: tremors, rigidity, akinesia, and loss of postural reflexes, right? And see, tremors need not be always be present in Parkinsonism. So in certain group of individuals, tremors may be absent as well. Okay, right. Now, see, if a patient with Parkinsonism, if he is confined to wheelchair, and this we call it as red flag sign in Parkinsonism. This we call it as red flag sign in Parkinsonism. Okay. Now, what is the treatment in these patients with the Parkinsonism? Okay. Before going to that, you need to know some of the frequently asked questions. The type of tremors will be resting tremors, and the frequency is 4 to 7 hertz. Coming to rigidity, in case in upper limbs you have cogwheel rigidity, in lower limbs you have lead pipe rigidity. Okay. Then next is reflexes. The postural reflexes are lost. Then how will be the gait, the characteristic gait, that is called festinate gait, where the individual will have short shuffling steps with stooped posture. Short shuffling steps with stooped posture. And bradykinesia. And if you take the handwriting of these individuals, they write small spidery letters, that is called micrographia. Expressionless face, that is called masked faces. And deep tendon reflexes are not affected, and plantar reflex will be the flexor response. And these patients, they'll have this characteristic Myerson sign which is being present, right? So where the individual blink reflex will be reduced. Okay, so these are some of the frequently asked questions in the topic of Parkinsonism. And then finally you need to know the first line drug. The first line drug in patients with Parkinsonism will be levodopa. Along with levodopa, you need to give a peripheral decarboxylase inhibitor, that is carbidopa. So you need to give levodopa plus carbidopa, right? But in those individuals who already have levodopa induced dyskinesia, in them you need to give dopamine agonist as the drug of choice. Okay, please listen here. Actually, levodopa is a first line drug. But in those individuals who have already the involuntary movements, that is dyskinetic movements, in them you need to give your dopamine agonist, that is in the form of apomorphine, rotigotine, bromocriptine, cabergoline, pergolide, then pramipexole or ropinirole should be given. And the other drugs are what? Monoamino oxidase inhibitors, that is rasagiline and salicyline. Then COMT inhibitors are entacapone and as well as tolcapone. Then you have anticholinergic drugs. These anticholinergic drugs are like the benztropine, piperidine, orphanidine, procyclidine, and trihexyphenidyl. So these are the group of drugs which are given in the treatment of Parkinsonism. But the first line drug is levodopa. But when these particular patients are taking levodopa for a prolonged period of time, there is chance of development of on and off phenomena. Okay, right. Now, after having discussed about your Parkinsonism, so in Parkinsonism, where exactly will be the defect? That is in case of substantia nigra. But what are the other basal ganglia disorders? That includes the athetosis. In athetosis, the site of pathology will be within the globus pallidus, right? Site of pathology will be in the globus pallidus. And what will be the manifestations? That is the continuous writhing movements. It is not reading movements, I'm sorry. It is continuous writhing movements that will be there within the hands, arm, and as well as neck. Whereas hemibalismus, the site of pathology will be in the subthalamic nucleus, and the manifestation will be sudden flailing movement of the entire limb. Next is the chorea. The site of pathology will be in the caudate nucleus and as well as the putamen, right? And for the development of chorea, what will be the manifestations in chorea? That will be flicking movements in the hands and as well as the face. So what are all your basal ganglia disorders? Parkinsonism, the site of pathology in substantia nigra. Athetosis, site of pathology is in globus pallidus. Hemibalismus, site of pathology in subthalamic nucleus. Chorea, the site of pathology is in the caudate nucleus and as well as putamen. Right. Now, after having discussed about your basal ganglia disorders, that is Parkinsonism, you need to know about atypical Parkinsonism. See, what is the difference between your typical and as well as atypical Parkinsonism is that in these patients with atypical Parkinsonism, along with the features of Parkinsonism, there is early development of autonomic symptoms, right? There is early development of the autonomic symptoms and some additional features will be there. And what are all your the atypical Parkinsonism? That is your progressive supranuclear palsy, multi-system atrophy, and as well as corticobasal degeneration. So these three, let me discuss quickly. So in case of progressive supranuclear palsy, initially the lower gaze palsy will be there. Followed by that, there is involvement of superior colliculus. And because of the involvement of superior colliculus, what is the function of superior colliculus? That is mainly to maintain the vertical gaze. So these patients, they'll have vertical gaze palsy, and that is the reason why they'll have recurrent falls, right? Recurrent falls will be there. And the rigidity, there will be cogwheel and as well as leg pipe rigidity, and bradykinesia will be there. And electrooculogram will show you the characteristic, the square wave jerks. What is the square wave jerks? The square wave jerks is that you cannot appreciate that within the eye movement, but when you measure this eye movements, that will be in this characteristic square wave jerks. See, square root sign is different. Square root sign is present in constrictive pericarditis in the cardiology, whereas here it is the square wave jerks, right? And in these patients with progressive supranuclear palsy, when you do an MRI, you have this characteristic hummingbird appearance in case of progressive supranuclear palsy. And these patients, they have very poor response to levodopa, right? That is another important difference. In typical Parkinsonism, good response to levodopa, whereas here there is poor response to levodopa. Which one? The atypical Parkinsonism. And another important form of atypical Parkinsonism is Scheidegger syndrome, which is also called the multi-system atrophy, that is MSA. Now, in case of Scheidegger syndrome, what are the important features? Along with bradykinesia and as well as rigidity, right? Within 1 year, there will be development of autonomic insufficiency. And because of autonomic insufficiency, they'll have postural hypotension causing recurrent falls. And because of autonomic insufficiency, they also have the constipation. And you have what is called MSAC. MSAC stands for the cerebellar involvement. That means they will have cerebellar manifestations in the form of gait ataxia and as well as the intentional tremors. That is what is your Scheidegger syndrome or multi-system atrophy. Now, what is the MRI finding? In progressive supranuclear palsy, that is hummingbird appearance. Whereas here, you get what is called as the hot cross bun sign. So, this is what is the hot cross bun sign. So, you can see that here. That is what you will see in case of your multi-system atrophy, which is also called Scheidegger syndrome. And one more form of atypical Parkinsonism is corticobasal ganglion degeneration. What are the features of your CBD? The features include the asymmetrical dystonia, apraxia will be there, that is loss of visual spatial skills, focal limb myoclonus, and alien hand syndrome. What is this alien hand syndrome? There will be some involuntary movement within the hand and the patient says that I am not moving, it is involuntary moving by itself. That is alien hand syndrome. So these are the three important atypical Parkinsonism. That is your Scheidegger syndrome, which is nothing but your multi-system atrophy, progressive supranuclear palsy, and as well as the corticobasal degeneration. Now, what is the important difference between your typical Parkinsonism and atypical Parkinsonism is your Parkinsonism asymmetrical manifestations will be there, whereas atypical, it is symmetrical manifestation except your CBD. CBD, again you have symmetrical involvement. Good response to dopamine, that is levodopa in Parkinsonism, poor response here. Tremors, they are usually present in case of Parkinsonism, that is resting tremors. Occasionally, they may be absent. In atypical Parkinsonism, tremors may or may not be present. Whereas in case of the Parkinsonism, it is your peripheral rigidity. Whereas here, that is axial rigidity, that is what you will have in case of atypical Parkinsonism. So this completes the discussion related to your Parkinsonism. So once we are done with the Parkinsonism, we'll move on to the next topic, that is the meningitis. So what exactly is your meningitis? See, if you see this particular question of meningitis, bacterial meningitis is an acute purulent infection within the, right? So it is within the subarachnoid space. Please remember, it is not in the subdural or extradural space. And one more next important question is, most often responsible for community acquired bacterial meningitis. Please remember, the answer is the Streptococcus pneumonia. And what is the organism that is responsible for post meningitis deafness, that is the Haemophilus influenza, right? Very, very important. Now, in patients with meningitis, you have a triad of manifestations. What is the triad of manifestations? High grade fever will be there, and severe headache and neck rigidity will be there, right? And apart from that, they'll have this projectile vomiting, photophobia, decreased consciousness, and because of raised intracranial pressure, there can be papilledema. These are the other associated manifestations. But the triad is high-grade fever, headache, and as well as the nuchal rigidity. Now, yes, this particular nuchal rigidity is due to what? That is due to inflamed meninges, which are passing down even down to the spinal cord. So whenever you try to flex this inflamed meninges, the individual will have the neck stiffness. And the other two important signs of meningitis is, apart from neck rigidity, Kernick sign and as well as the Brudzinski sign. What is this Kernick sign? Where the individual is made to lie down in supine position with passively flexed hip and as well as knee. And when you try to extend the knee, the individual will not be able to extend the knee. So knee cannot be fully extended, the individual will have severe pain. And Brudzinski's neck sign is that when you flex the neck, automatically the legs can be flexed. So that is what is the Brudzinski sign. Now you take the workup in patients with meningitis. See, what is the correct sequence to be followed in suspected bacterial meningitis? So you have three things. One is your blood culture. When will you give antibiotics? When will you do lumbar puncture? So these three things, they'll give you permutations and combinations. Always remember, in case of a suspected bacterial meningitis, you need to draw the blood culture first. Then you give an empirical antibiotic. Then you do a neuroimaging to look for if there is any intracranial space occupying lesion causing a very high intracranial pressure. And if there is no intracranial space occupying lesion, then you need to do lumbar puncture. So before the lumbar puncture, neuroimaging is mandatory. So this is the sequence that you need to follow in a suspected case of bacterial meningitis. And whenever you are doing lumbar puncture, where exactly is the site where you will do lumbar puncture? That is in between L3 and L4. And what is the needle that we use for doing the lumbar puncture? That is the Quincke's needle and as well as the Sprott's or the Sprott's needle. And please don't get confused with the Quincke's sign. Quincke's sign is that what you see in the nails within the aortic regurgitation, right? Now, whenever you take out the CSF, how much is the CSF that you need to remove? 20 to 30 ml you need to remove. And the rate of production of the CSF by your choroid villi in the ventricles is 20 ml per hour. And what is the total amount of CSF in the subarachnoid space? That is 150 ml. And these patients, post lumbar puncture, they will have headache. So they have to be advised the bed rest. So how can you determine that particular headache is because of your lumbar puncture headache? Remember, if the headache increases on straining, it is nothing but your post lumbar puncture headache. And the CSF analysis is very, very important in case of the meningitis. So you take in all the forms of meningitis. See, normally the CSF pressure is normal. And how much is that normal CSF pressure? That is around 50 to 180 millimeters of water, right? And in all the forms of meningitis, right, in all the forms of meningitis, the CSF pressure will be elevated. Not in Guillain-Barré syndrome, okay? It is not an infection, right? Now, you take the color. The normal color of the the normal color of the CSF is like clear. It is like water. And how many cells will be there? 0 to 4 cells per cubic millimeter, predominantly lymphocytes. And the glucose will be 2/3 of the plasma glucose. And proteins will be around 15 to 45 milligrams percentage. Right? So this is the normal CSF picture. Whereas you take in bacterial meningitis now, the color, like what will be the color of it? It will be turbid. And what will be the cells? It is the neutrophilic predominant. And the glucose will be utilized by the growing bacteria. So glucose will be reduced and the proteins will be elevated. Why? Because the antibodies are formed against the bacteria, and these antibodies are nothing but the proteins in case of the tubercular meningitis. In case of tubercular meningitis, what is the color of the fluid? It will be straw colored fluid. And what will be the cells? It will be lymphocytic predominant. Right, lymphocytic predominant. Nearly 100 cells per cubic millimeter will be there, and even your tuberculous organism will utilize the glucose for survival. So CSF glucose will be reduced and proteins will be elevated. The antibodies are formed against Mycobacterium tubercle bacilli. Then you take viral meningitis. In viral meningitis, more or less, the CSF color will be clear. There will not be any change, but the cells, it will be lymphocytic predominant. And the glucose, in case of viral meningitis, it will be normal. Proteins are elevated. Whereas you take in Guillain-Barré syndrome, everything will be normal. The only thing is there will be classical albuminocytological dissociation. That means albumin levels will be very high and albumin level will be very high. The cells will be normal in case of Guillain-Barré syndrome. That we call it as albuminocytological dissociation. And the differential diagnosis for albuminocytological dissociation is even the Freund syndrome. Then coming to fungal meningitis. You take fungal meningitis, the color of the CSF will be clear, there will not be change. And even here also it is lymphocytic predominant. The glucose will be low and the proteins will be increased. So this is about the CSF picture in all the forms of meningitis. And you need to know some of the image-based questions, right? So the CSF is collected in a test tube and kept bedside. And this particular coagulum is formed. What is that? Cobweb coagulum. Where do you see that? That is in case of tubercular meningitis. And one more important is the rich focus, right? What exactly is the rich focus seen in patients with tubercular meningitis? It is basically a tuberculous granuloma which is occurring within the cerebral cortex. And once this particular rich focus, if it is rupturing, it ruptures into the subarachnoid space, causing the tubercular meningitis. Okay, that is called rich focus. And the name is given in the favor of a scientist, that is Arnold Rice Rich, who has discovered this first, right? So that is what is called as the rich focus. He is a pathologist, right? He is a pathologist, right? So this is about your meningitis story. The only one thing you need to know in case of bacterial meningitis, like the drug of choice will be ceftriaxone, and that too 2 grams of ceftriaxone you need to start empirically. Along with that, you need to give vancomycin. And tubercular meningitis, you need to give ATT. Then viral meningitis, we give the acyclovir, and fungal meningitis, we give your liposomal amphotericin B, right? Because the cryptococcal meningitis is more common. So that is about the treatment of your meningitis. So once we are done with the topic of meningitis, then the next important discussion is about the motor neuron disease. See, in these patients with motor neuron disease, please remember it is purely motor involvement. Sensory manifestations will never be there. Okay, so what is pathognomic for motor neuron disease? Fasciculations, bowel and bladder involvement, pseudohypertrophy, sensory loss in patchy manner. That is fasciculations. Bladder and bowel involvement will not be there. Pseudohypertrophy will not be there. Sensory loss in patchy manner will never be there in patients with motor neuron disease. And this motor neuron disease, what is the age group at which this you commonly see? That is around 30 to 60 years of age. And the motor neurons which are being affected is either lower motor neuron or upper motor neuron, or in some individuals there is involvement of both lower motor neuron and as well as upper motor neuron. Okay, now what is that lower motor neuron involvement at the level of spinal cord? That is anterior horn cell or the cranial nerve nuclei, right? Or the cranial nerve nuclei. And what is that upper motor neuron which is being affected? That is corticospinal tract at the level of spinal tract or spinal cord, or corticobulbar tract at the level of cerebral cortex. And lower motor neuron and upper motor neuron involvement can also be there. Now, and what is the most common risk factor for the development of motor neuron disease? That is the cigarette smoking. Now, you need to know that the conditions where there is involvement of both upper and lower motor neuron involvement, that is amyotrophic lateral sclerosis. Only upper motor neuron involvement, that is primary lateral sclerosis. Only lower motor neuron involvement, that will be spinomuscular atrophy. And among all these, which is most common? Amyotrophic lateral sclerosis, where there is involvement of both upper and lower motor neuron involvement. And the most common cause of death in patients with motor neuron disease will be respiratory failure due to respiratory muscle paralysis. And in case of amyotrophic lateral sclerosis, what are the drugs that we can give is, we have two important drugs. One is riluzole, the other one is edaverone. So these are the two drugs for amyotrophic lateral sclerosis. And what does this riluzole do? This particular riluzole and edaverone, that will prevent the progression of the amyotrophic lateral sclerosis by preventing the glutamate release. So glutamate is the one which is a neurotransmitter which is being released, causing free radical damage. But this riluzole will prevent the release of the glutamate. And same thing is even your edaverone. It is a free radical scavenger. Okay, but you take in case of the SMA, right? You take in case of the SMA, spinomuscular atrophy, the drugs like what we have is nusinersen, and this is the costliest drug. The treatment is around 14 to 16 crores. Okay, and that is a gene therapy, and it works well. It works well. That is onasemnogene gene. So this is the treatment for spinomuscular atrophy. So that completes the discussion of the motor neuron disease. Right? We are done with this. Now, so which is the most common form of motor neuron disease? That is amyotrophic lateral sclerosis. What are the drugs that can prevent the progression? That is riluzole and as well as the edaverone. Now, once we are done with the motor neuron disease, the next important topic is the multiple sclerosis. So multiple sclerosis is what? Multiple sclerosis, it is a demyelinating disorder of the central nervous system. And what is a disorder where there is demyelination of peripheral nervous system? That is Guillain-Barré syndrome. I'll discuss that. Okay. Now you see this question. Drug that causes maximum reduction in appearance of new lesions and change in the disease severity in relapsing remitting multiple sclerosis. Right? What is that particular drug? That will be natalizumab. Natalizumab is the one which will cause maximum reduction in the severity of your RRMS. Now, if you take this multiple sclerosis, what did I tell you? It is the demyelinating disorder of the central nervous system, and it is very commonly seen in individuals with HLA-DR2, right? HLA-DR2. And what are the other etiologies? The other etiologies is environmental multiple sclerosis, and this environmental multiple sclerosis is due to vitamin D deficiency. And this multiple sclerosis can also occur secondary to infection, that is Epstein-Barr virus infection. So that is what is the etiology causing multiple sclerosis. And if you know, if you see here, what is the most common clinical pattern of multiple sclerosis? Most common clinical pattern of multiple sclerosis is RRMS, that is relapsing remitting multiple sclerosis. So these are the clinical patterns of the multiple sclerosis. Now, yes, you take this is RRMS, right? In RRMS, you have a relapse and you have a remission. What is this second one? PPMS, that is primary progressive multiple sclerosis. So here there are no acute attacks. There will be gradual worsening of the disease. That is your PPMS. And the other one is your SPMS, that is secondary progressive multiple sclerosis. So initially it will be like RRMS. Later it will be like progressive multiple sclerosis. That is the reason why it is called SPMS. Then the other one is your PRMS. What is this particular PRMS? PRMS, it is primary progressive multiple sclerosis. So from the beginning itself, there will be a progression, and upon that you have the acute episodes. That is your primary progressive multiple sclerosis, and this is the one which has the worst prognosis, right? And among the clinical features, what do you think is the most common clinical feature? That is sensory loss, that is in the form of paresthesia. And most common cranial nerve which is being affected is the optic nerve. There will be development of the optic neuritis, and there can be demyelination of your corticospinal tract also, thereby there will be weakness, right? And not only that, there will be also demyelination of your 9th and 10th nerve, because of which there can be also dysphagia, right? And there can be also demyelination of your trigeminal nerve, right? And there can be also demyelination of your cerebellar structures. That is the reason why the individual can also have ataxia and as well as vertigo, and even bladder involvement will also be there in these patients with the multiple sclerosis. And next important thing is about the Uthoff's phenomenon. Uthoff's phenomenon in case of multiple sclerosis is due to decreased conduction of the nerves. That is what is your Uthoff's phenomenon, right? Decreased conduction of the nerves. And you take the next important sign, that is Lambert sign. That is also seen in patients with the multiple sclerosis. What is Lambert sign? Lambert sign is that whenever the individual flexes the spine, there will be electric shock like sensation down the spinal cord. That is called Lambert sign, or which is also called Barber chair sign. Then what is the investigation which is being important here is the MRI. So what will the MRI show? MRI will show you the presence of plaques. Where are these plaques present? In the periventricular area, and that gives you an appearance what is called as the Dawson's fingers. And when you do a CSF analysis in these individuals, you get this characteristic oligoclonal bands containing IgG antibodies. And what is the name of the criteria here? The name of the criteria for multiple sclerosis is, that is nothing but the McDonald's criteria. That is nothing but McDonald's criteria, right? And we have variants of multiple sclerosis, that is called Devick's disease, which is also called neuromyelitis optica. Here, in case of Devick's disease or neuromyelitis optica, along with optic neuritis, there is extensive transverse myelitis of more than or equal to 3 vertebral segments, right? There is extensive transverse myelitis of more than or equal to 3 vertebral segments. That is what is called Devick's disease or the neuromyelitis optica, right? Now, after having discussed about the variants, now we'll move on to the treatment. So, a 30-year-old female presents with complaining of gradual onset of weakness of legs for 1 month, with reduction in visual acuity and urinary incontinence for past few days. Contrast MRI show periventricular lesion. Which of the following is not used in these patients? Fingolimod, beta interferon, glatiramer acetate, mitotine. Please remember, the answer here will be the mitotine. The mitotine is the one which is used in the treatment of Cushing's, not in case of multiple sclerosis. And in case of multiple sclerosis, you need to know what is the drug which is given in acute episodes. In acute episodes, the drug that we give is methylprednisolone. But what are the disease modifying therapy? The disease modifying therapy, these are all the drugs which are your disease modifying therapy, and even your interferon beta. right? Interferon beta, glatiramer acetate, natalizumab, fingolimod, metoxantrone, dimethyl fumarate, teriflunomide, and as well as alemtuzumab. So these are all the drugs, right? Now, after having discussed about multiple sclerosis, the next important topic is the epilepsy, right? So in epilepsy, you need to know what are all the various types of epilepsy, right? And what is the drug of choice in the various types of epilepsies, right? So you take the first one, that is your GTCS. GTCS, atonic seizures, myoclonic jerks, and absent seizures more than 4 years. The drug of choice will be the valproic acid. There is no doubt in that. Whereas you take in febrile seizures during the episode of the febrile seizures, either we give rectal diazepam, right? Either we give rectal diazepam or you need to give intranasal midazolam, right? Intranasal midazolam. Then what is the prophylaxis that we give for the febrile seizures? The prophylaxis that we give is the oral diazepam. That means when the child temperature, if it is like reaching up to like 104, 105, then we should give this oral diazepam to prevent the development of the febrile seizures, right? Then absent seizures less than 4 years, the drug that we give is, right, the drug that we give is ethosuximide. Why is that we don't give the valproic acid? Because valproic acid is hepatotoxic. The child less than 4 years cannot bear that particular hepatotoxicity caused by valproic acid. That is the reason why we give ethosuximide. Whereas infantile spasm, the drug of choice will be the adrenocorticotropic hormone. Whereas infantile spasms in tuberous sclerosis, the drug of choice will be vigabatrin. Drug of choice will be vigabatrin. Whereas in status epilepticus, the drug of choice will be lorazepam, and in refractory status epilepticus, what we give is the midazolam. Okay, so these are the drug of choices in various types of epilepsy, and we have a terminology called medically refractory epilepsy. Medically refractory epilepsy, in these patients, you need to give the type of diet is ketogenic diet, vagal nerve stimulation, deep brain stimulation, and best results are seen with surgery, mainly in case of temporal lobe epilepsy. So these are all the options for the medically refractory epilepsy. And in the recent days, the commonly used drugs are valproic acid and lamotrigine, right? So regarding the valproic acid, you need to know in and out of valproic acid, right? You need to know the adverse effects of this valproic acid. So just remember this particular mnemonic, that is valproic. V stands for vomiting or nausea, A stands for anorexia where there is loss of appetite, L is your liver toxicity because of which the serum ammonia levels are elevated, AST and ALT are elevated. Pancreatitis because of which the question may give you that there is increase in amylase levels. R stands for retention in weight where the individual can have obesity development. O is edema, A is alopecia, T stands for teratogenicity. What is the teratogenicity associated with valproic acid? That is the spinal cord defect, right? There will be development of the spinal cord defect with valproic acid. That is the teratogenicity. That is the reason why the individuals who are planning to conceive, right, they should discontinue the valproic acid. Okay, and E stands for the enzyme inhibition. Okay, so these are all the adverse effects of valproic acid. Next important is, these are some of the image based questions related to the anti-epileptic drug. So which particular anti-epileptic drug will cause gum hypertrophy and as well as the hirsutism? That will be your phenytoin. And what is the teratogenicity associated with phenytoin? The development of the cleft lip and as well as the cleft palate. So that is what is nothing but your fetal hydantoin syndrome. Okay, so this completes the discussion of your epilepsy. And the next important topic for the discussion is the dementias, right? So in the dementia, the most common in elderly individuals will be the Alzheimer's, right? So this is another, which particular part of the brain is affected in Alzheimer's? That is the temporoparietal lobe. And you need to remember 4 A's in Alzheimer's. That is amnesia, that is earliest manifestation, apraxia, aphasia, agnosia. So these are the 4 A's that you need to remember in case of the Alzheimer's. And which particular part of the brain is affected in Alzheimer's? That is the temporoparietal lobe. Whereas in Pick's disease, which is also called frontotemporal dementia, it is the frontal and as well as temporal lobe. Whereas in case of Alzheimer's, it is the temporoparietal lobe which is being affected, right? Now, if you take the histopathological accumulations, you have extracellular accumulation and intracellular accumulation. Extracellular accumulations, that will be beta amyloid plaque, that will be the earliest manifestation. Intracellular accumulation, that will be neurofibrillary tangles, that is nothing but your tau protein. And more the tau protein accumulation, more will be your dementia, right? More will be your dementia. Okay, so the accumulation of your tau protein will determine the severity of dementia. And how do you manage these patients? Okay, management, the drugs that you need to give in case of mild to moderate form is donepezil, galantamine or rivastigmine. Whereas in moderate to severe form, like we need to give memantine, which is NMDA receptor antagonist. So this is the treatment for your the Alzheimer's disease. And the another important form of dementia is the Lewy body dementia. So in Lewy body dementia, you need to remember what are the core manifestations. The core manifestations are there will be early visual hallucinations, REM sleep abnormality, that means there will be variability with the tone of the muscles. And third important is delirium, that too fluctuating delirium or episodic, and Parkinsonism. These are the core manifestations of Lewy body dementia. And other manifestations are the Capgras syndrome, then syncopal episode, autonomic dysfunction, and this is very, very important. Memory is not affected in case of the Lewy body dementia, right? And what exactly is your Capgras syndrome? See, Capgras syndrome, it is the delusion of doubles, right? Delusion of doubles. That is nothing but delusional misidentification syndrome. So in Capgras syndrome, it is a syndrome which is being characterized by a false belief that an identical duplicate has replaced someone significant to the patient. So this is nothing but delusion of double. That is what is called the Capgras syndrome, which is seen in patients with the Lewy body dementia. So remember, in case of Lewy body dementia, the manifestations will be early visual hallucination, REM sleep abnormality, delirium, that too fluctuating in nature, Parkinsonism. These are the core manifestations. These are the core manifestations. Right. Okay, right. Now, after having discussed about the dementia, the next important is the prion disease. So, first and foremost, you need to know what exactly are the prions. There is a question also. Which of the following statement about prion is true? They are infectious protein. They are made up of bacteria and virus. They have rich nuclear material. They can be cultured in the cell-free media. This is one of the PYQ. Remember, prion is nothing but it's an infectious protein. They don't have any nuclear material, no RNA, no DNA. It's an infectious protein, right? And if you see these important points, so prions are infectious proteins which are devoid of DNA or the RNA. No DNA, no RNA, right? And there is accumulation of abnormal protein, right? There is accumulation of prion protein, right? Accumulation of prion protein. And these particular prions are most resistant to physical and as well as chemical agents, right? They are most resistant to the physical and as well as the chemical agents, right? They are resistant to heat, resistant to irradiation, resistant to formalin, right? But they are sensitive to proteases, right? They are sensitive to proteases because they contain proteins, but they are resistant to nucleases. They don't respond to nucleases because they don't have the nucleic acid, right? And the disease which is being caused by prions, they include human prion diseases and as well as animal prion diseases. But what is our point of interest is the human prion disease. So human prion disease, like you have Creutzfeldt-Jakob disease, which is common, Kuru, then fatal familial insomnia, then Judgment-Schrinker-Schonker syndrome. So these are human prion diseases. Now let me discuss about the human prion disease, that is Creutzfeldt-Jakob disease. So if you take this Creutzfeldt-Jakob disease, what is the very, very important manifestation? Just remember CJD, right? CJD, that is C stands for clonus. So the very important manifestation here is the myoclonus, right? The very, very important manifestation is the myoclonus. Okay, and J stands for just like that, just remember like. D stands for dementia. So this is what is your CJD in case of Creutzfeldt-Jakob disease. Then how do you diagnose this particular CJD? So diagnosis of CJD can be done by your EEG, can be done by CSF analysis. So CSF analysis will show you a characteristic protein. What is that characteristic protein? That is your 1433 protein is being elevated within the CSF, right? It is being elevated within the CSF. What is this 1433 protein? See, 1433 proteins, they are family of conserved regulatory molecules that are expressed in eukaryotic cells, and they get expressed whenever there is accumulation of infectious protein, that is the prions. Okay, that is 1433 protein is being elevated. Then what will be the characteristic EEG pattern? The characteristic EEG pattern will be the triphasic wave pattern, right? The characteristic EEG pattern will be triphasic wave pattern. But this triphasic wave pattern is not just seen only in patients with the Creutzfeldt-Jakob disease. Triphasic wave pattern can also be seen in case of metabolic encephalopathy, can also be seen in case of hepatic encephalopathy, right? And where exactly will be the pathology when you do an MRI in these patients? You will observe the pathology is in the caudate nucleus and as well as putamen, right? And do you have any treatment for this Creutzfeldt-Jakob disease? There is no specific treatment in these patients with the Creutzfeldt-Jakob disease, right? So this is about your CJD. Now, one important topic that is being left out is about the GB syndrome, that is the Guillain-Barré syndrome. Now, if you take this Guillain-Barré syndrome, what type of disorder is this? This Guillain-Barré syndrome, please remember, it is the demyelinating disorder of the peripheral nervous system. Whereas multiple sclerosis, what did I tell you? That is a demyelinating disorder of the central nervous system, right? Demyelinating disorder of central nervous system. Whereas here, it is a demyelinating disorder of the peripheral nervous system. And in order to develop this Guillain-Barré syndrome, there should be some pre-existing infection. Either the respiratory tract infection or the gastrointestinal infection should be there for the development of the Guillain-Barré syndrome. So, what type of hypersensitivity reaction is this? It's a type 4 hypersensitivity reaction. Why? Because these patients, they will have 8 to 10 days before a respiratory tract infection by the viruses, or there will be gastrointestinal infection by certain bacteria, right? After 8 to 10 days, the pathology or pathogenesis will be in the form of molecular mimicry. The antibodies that are being formed against these particular organisms, these antibodies, they will go and attack the myelin sheath which is present in the peripheral nerve, causing the peripheral demyelination. So that is the reason why it is a type 4 hypersensitivity reaction. Now, which of the following is the most common antecedent infection? Remember, you have viral and bacterial infection. The most common is bacterial infection, that is the Campylobacter jejuni, right? Now, what is the earliest manifestation in Guillain-Barré syndrome? That is distal areflexia. That is, the ankle jerk is being lost. That is the earliest manifestation in case of the Guillain-Barré syndrome. And the type of paralysis that you will see in Guillain-Barré syndrome is lower motor neuron type of paralysis. That is, flaccid paralysis will be there. And the type of paralysis will be ascending paralysis. So initially the lower limbs will be affected, then trunk muscles, then upper limb muscles, and finally respiratory failure will be there. So type of respiratory failure that you will see in the Guillain-Barré syndrome will be type 2 respiratory failure. Why is that? Because of the involvement of the respiratory muscles. And if you see the cranial nerves which are being affected here, it is bilateral seventh nerve palsy that you will see in patients with the Guillain-Barré syndrome. And these patients, they will also have the autonomic involvement, due to which there can be postural hypotension, there can be brady or tachycardia, and there can be also profuse diaphoresis, right? And you have 4 important forms of Guillain-Barré syndrome. These are the 4 important forms. Out of which, what is the most important form? The most important form is your AIDP, that is acute inflammatory demyelinating polyneuropathy, right? Now, the next important is, let us discuss about the MFS, that is Miller-Fisher syndrome. So, what is the most common cranial nerve which is affected in Miller-Fisher syndrome? 7th, 3rd, 6th, 10th. Please remember, it is the oculomotor nerve which is being affected in Miller-Fisher syndrome. So, in Miller-Fisher syndrome, as such, a rare variety, and the earliest manifestation in Miller-Fisher will be the cranial nerve involvement. And what is that cranial nerve which is being affected? That is oculomotor nerve which is being affected. And this is characterized by a triad, and that particular triad is OAA. What is this OAA? Ophthalmoplegia, areflexia, and ataxia. And what is the antibody in Miller-Fisher's? That will be anti-GQ1. Whereas in Guillain-Barré syndrome, that is AIDP, that is anti-GM1 antibody. But whereas here, it is anti-GQ1 antibody that you need to know. And how will be the prognosis in patients with Guillain-Barré syndrome? It's a good prognosis. But only in 5% of patients, they may go into total motor paralysis, where there is involvement of respiratory muscles causing the death of the individual. Then what will be the CSF finding? The CSF finding will be in the form of albuminocytological dissociation. Albumin level will be very high and cells will be normal. And the same thing, what is the differential diagnosis for your albuminocytological dissociation? That is Freund syndrome. What is Freund syndrome? That is nothing but the spinal block by the tumor. That is what is called the Freund syndrome. The other investigations are nerve conduction studies will show you demyelination, right? And nerve conduction studies also will show you that F reflex latency is increased. MRI will show you that there is demyelination of the peripheral nervous system, and investigation of choice will be anti-GM1. Whereas for Miller-Fisher's, that is anti-GQ1. Then how do you treat these patients with the Guillain-Barré syndrome? See, Guillain-Barré syndrome, there are two important methodologies. Drug of choice will be IVIG and then plasmapheresis. There is no role of steroids here. There is no role of steroids in patients with the Guillain-Barré syndrome. Okay, so this is about your Guillain-Barré syndrome. So with this, we are done with the discussion related to the topics of the entire neurology. So these are all the topics which we have covered in this quick revision of 2 hours of the neurology, right? So we'll just have a quick break for 10 minutes, then we'll come back and start the nephrology quick revision, right? So yes, and if you have any doubts in the neurology, you can text me in the chat box, right? I'll answer to you, right? So you just take a break for 10 minutes, and this particular PDF, immediately after the session is over, I'll try to send to you on my Telegram channel, okay? Right, so just take a break for 10 minutes. Venkat. ఇప్పుడు అది నిన్న నీకు పెట్టే చూడు, అది ఓపెన్ ఉందా చూడు రెస్టారెంట్. పెట్టేసాయి ఆ రోల్, దాని తర్వాత రైట్ వచ్చాక ఫ్రిడ్జ్లో పెట్టేసాయి.
Speaking to someone else. ಕರೆ ಮಾಡುತ್ತಿರುವ ವ್ಯಕ್ತಿ ದಯವಿಟ್ಟು You have speaking to someone else. You can wait or call again. మీరు కాల్ చేస్తున్న వ్యక్తి.
హలో వెంకటేష్. ఎవరు ఆయన? సిహెచ్ వెంకటేష్. ఇప్పుడు నేను ఇప్పుడు యాక్చువల్గా మాదాపూర్లో ఉన్నాను, క్లాస్లో ఉన్నాను నేను. నేను ఉపేందర్ చెప్పాడు కదా, నాది అయిపోయేసరికి 11, అదే సేమ్ నిన్న టైం అవుతుంది. ఆ! ఉందా? ఆ! ఆ! ఐటమా? నీకు పెట్టాను గదా నిన్న. అంటే నువ్వు వేరేది సెలెక్ట్ జేసినట్టున్నావు. వేరే ఇస్తా 2 ఉన్నట్టున్నాయి. అదొకసారి జూసి సెలెక్ట్ జేసుకో. వేరే ఇస్తా సెలెక్ట్ చేసుకో. నేను వస్తాను వెంకటేష్, మరి 11:30కి అట్లా వస్తాను నీ దగ్గరికి. సరేనా? 11:30, 12 అయితుండొచ్చు, వస్తాను నేను. హ్మ్. చెప్పి పెట్టమని చెప్పు వాళ్ళకి. నిన్నొచ్చి రాసి నేను సంతకం పెడతా. హ్మ్. ఓకే. 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 అది 2 ఉన్నాయి ఇస్తా. ఆ! ఓన్లీ వెజ్. హ్మ్. ఇది. రైట్. ఇంకోటి దీంట్లో పెట్టావా? ఇంకోటి యాడ్ చేయనట్టున్నావు? ఆ! ఆ! హుహు. పర్లేదు. ఎయిర్ డ్రాప్ మళ్ళీ ఆఫ్ చేసినట్టున్నావు. ఎయిర్ డ్రాప్ ఒకసారి ఓపెన్. ఒకటి. సరే దిప్ప దూకుంటాను. అసలు రావట్లే ఈరోజు. బాగా వేడిగా ఉంది. టెంపరేచర్ గిన ఎక్కువ ఉందా ఏంటి? రైట్. దాంట్లో ఓపెన్ చేయలే. అది ప్రాంప్ట్ ఫైల్ నీకు వేరేది ఇచ్చిన దీంట్లో పంపించలే నీకు అది. దేనికి పంపించాలి నీకు? వచ్చింది కదా. Right. So after having discussed about the neurology quick revision, now let us just take up the nephrology quick revision. So the PPT of this nephrology quick revision has already been posted in Dr. Banu Prakash Telegram channel and as well as my Telegram channel, that is Medicine Made by Dr. Rajesh Gupta. So immediately after the session, I'll also post the PPT with annotations as well. So now in the nephrology quick revision, what all the topics that we'll be discussing is the acute kidney injury, chronic kidney injury, nephrotic nephritic syndrome, polycystic kidney disease, renal tubular acidosis, and as well as the hereditary nephropathies, that is Bartels, and as well as the Gentleman's and Alport syndrome as well. Now, let us take up the discussion of the acute kidney injury first. So, if you take the acute kidney injury, like what should happen here? There should be abrupt increase in serum creatinine. So, how much should be increase in serum creatinine levels in acute kidney injury? It should be more than or equal to zero point 0.3 milligrams per deciliter. That should be elevated within 48 hours. That should be increased within 48 hours, or there should be a decrease in the urine volume. And how much should be the decrease in urine volume? Decrease in urine volume should be less than 0.5 ml per kg per hour, and this particular decrease in urine volume less than 0.5 ml per kg per hour, that should be there for nearly around 6 hours. Okay, so this is the definition of acute kidney injury according to your KDIGO guidelines. And what is the normal urine output? So if you take the normal urine output is 1 ml per kg per hour. That is a normal urine output. But whereas in acute kidney injury, it is less than 0.5 ml per kg per hour for nearly around 6 hours. Now, what exactly is the definition of the anuria? See, anuria is defined as the urine output less than, right? This is one of the PYQ. So please remember the answer is less than 4 ml per hour. Now, see, according to the KDIGO guidelines, this is the definition of acute kidney injury. But we have one more important criteria, that is called acute kidney injury network criteria. In the acute kidney injury network criteria, what they have mentioned is the staging of acute kidney injury, that is stage 1, 2, 3. In stage 1, the creatinine is elevated 1.5 to 2 folds and the urine output is reduced less than 0.5 ml for more than 6 hours. Whereas in stage 2, the increase in serum creatinine is like 2 to 3 folds and urine output is being reduced less than 0.5 ml per kg per hour for more than 12 hours. Whereas in the stage 3, the serum creatinine is elevated more than 3 folds and the urine output is reduced less than 0.3 ml per kg per hour for 24 hours. So this is what is the staging of the acute kidney injury. Now you need to know the three important forms of the three important etiologies of acute kidney injury, that is pre-renal, intrinsic renal, and as well as the post-renal. So what is pre-renal? Prerenal means the perfusion to the kidney should be reduced. So the perfusion to the kidney will be reduced because of intravascular volume depletion. So the intravascular volume depletion can occur in hemorrhage, gastrointestinal loss, and as well as the renal loss. And the decreased renal perfusion can occur because of decrease in cardiac output. That is because of the congestive heart failure, aortic stenosis, or mitral regurgitation or aortic regurgitation. Then the decreased renal perfusion can also occur in renal vasoconstriction, which is being caused by the hypercalcemia, sepsis, or liver disease. And these are all the etiologies which will cause pre-renal. Pre-renal means where the perfusion to the kidney will be reduced. Then intrinsic renal. So intrinsic renal means the pathology will be within the kidney, right? So what will be that pathology within the kidney? Like we have some large vessel diseases, glomerular diseases, acute tubular necrosis, and interstitial diseases which will be causing intrinsic renal type of acute kidney injury. So out of this, acute tubular necrosis is very, very important. This acute tubular necrosis to occur, like we have the exogenous toxins and as well as the endogenous toxins. What are the exogenous toxins? Exogenous toxins are mainly the antibiotics, anti-cancer agents, and radio contrast material. And what are the endogenous agents? The endogenous agents are mainly myoglobinuria, hemoglobinuria, light chain, that is in case of multiple myeloma, and uric acid, that is in case of gout or gouty arthropathy, tumor lysis syndrome. That will be the endogenous cause for your acute tubular necrosis. Okay. Now, very important is you should be able to differentiate pre-renal from intrinsic renal, right? Pre-renal from intrinsic renal. Now you see this question: investigation in a patient of oliguria revealed urine osmolality 800 milliosmoles, urine sodium 10 millimoles, 1 to creatinine ratio 20:1. The most likely diagnosis is pre-renal acute tubular necrosis, acute cortical necrosis, urinary tract obstruction. So now how will you differentiate pre-renal from the intrinsic renal? So 2-3 parameters are there which are very, very important. What are those 2-3 parameters here? 1 to creatinine ratio. So if you take blood urea nitrogen to the creatinine ratio, if it is more than 20, that will be pre-renal. But if 1 to creatinine ratio, if it is like less than or equal to 20, if they are like less than or equal, I'm sorry, I'm sorry. If 1 to creatinine ratio, if it is less than 10 to 15, that will be the intrinsic renal. Right? How much is here? 20 is to 1. So this becomes your pre-renal type of the acute kidney injury. And one more important is the fraction excretion of sodium. So in pre-renal, the fraction excretion of sodium will be less than 1, whereas here it will be more than 1. So these are the two important parameters which will differentiate pre-renal from intrinsic renal type of acute kidney injury. Then followed by that, you need to know what are the post-renal causes for acute kidney injury. In males, the most common cause for post-renal type of acute kidney injury will be benign prostatic hyperplasia. That is the most common cause in males. And apart from that, the other etiologies that will be causing post-renal will be the renal calculi, ureteric calculi, the bladder stones, right? So these are all the post-renal cause for your the acute kidney injury. And next is the fibrosis, right? This particular fibrosis can occur in patients like scleroderma, or in the patient who is on drugs like bleomycin or methotrexate, right? Bleomycin or methotrexate. Even these can cause the fibrosis. So bilateral ureteric fibrosis, right? Bilateral ureteric fibrosis. This can cause post-renal type of acute kidney injury. Right, this can cause post-renal type of acute kidney injury. So what are the causes for bilateral ureteric fibrosis? Scleroderma and drugs like bleomycin and methotrexate. Okay, right. Now, what are the manifestations of your acute kidney injury? So we have initiation, maintenance, and diuretic phase. So in the initiation phase, there is just decrease in the renal blood flow. There is just decrease in the renal blood flow, and this will be there for up to 36 hours of onset of acute kidney injury. Whereas your maintenance or oliguric phase, here the GFR is reduced maximally. Right, here the GFR is reduced maximally in case of maintenance or oliguric phase, and this maintenance or oliguric phase will be there for nearly around 1 to 2 weeks. Will be there for nearly around 1 to 2 weeks. And in maintenance phase, you will have all the uremic complications, and you will have all the electrolyte abnormalities. What are all the electrolyte abnormalities that you can have in maintenance phase? Hyperkalemia, hyperphosphatemia, hypermagnesemia, hyperuricemia, right? And there will be elevation of blood urea nitrogen. So why do you think this electrolyte abnormality like hyperkalemia, hyperphosphatemia, hypermagnesemia, hyperuricemia, and elevated blood urea nitrogen will be there? That is because of reduced excretion, right? And they will have hyponatremia. Why is that? That is because of dilution. Dilutional hyponatremia will be there because of volume overload. Then there will be also hypocalcemia. Why? Because phosphate level is elevated. That increased phosphate will combine with calcium, resulting in the hypocalcemia. Then in recovery or diuretic phase, all the electrolyte abnormalities will be reversed, right? So this will be there after 2 weeks once you treat the patient, right? All the electrolyte abnormalities will be reversed. Hyponatremia will become hypernatremia, hyperkalemia will become hypokalemia, hyperphosphatemia will become hypophosphatemia, hypermagnesemia will become hypomagnesemia, hyperuricemia will become hypouricemia, but only thing which will be there is your hypocalcemia. That will persist. Why is that? Because calcium has been precipitated in the form of calcium phosphate. So that will be there even in your recovery or diuretic phase. So overall, if you take the clinical manifestations, the clinical manifestations are due to decrease in urine output, right? Decrease in urine output. There will be oliguria. So when do you call it as oliguria? You call it as oliguria when the urine output is less than 400 ml per 24 hours. Then you will have all the features of uremia. What are all the features of uremia? See, the urea level is elevated here, and this particular urea goes and gets accumulated in various parts of the body. So there can be uremic encephalopathy, right? There can be uremic pericarditis, there can be uremic gastroparesis. Okay, so these will be the features of the uremia, and you will also have the features of the fluid overload. So what will be the features of the fluid overload? That is the pleural effusion. There can be also development of the pericardial effusion, right? And there can be also development of ascites, and there can be also development of edema. So these are the features of the fluid overload. And in certain etiologies causing acute kidney injury, the color of the urine also changes. See, in case of the hemoglobinuria, you will have the red color urine. And in case of myoglobinuria, that is in case of rhabdomyolysis, you will have the brown colored urine. So these will be the clinical features of the acute kidney injury. Then how do you work up these patients? So first and foremost, definitely the serum creatinine. The serum creatinine level will be elevated, and even urea levels are also elevated. But when you do a complete blood picture, there will be anemia, right? There can be anemia, and eosinophilia will be there. But in which condition of acute kidney injury you will have the eosinophilia? Eosinophilia and eosinophiluria, it indicates atheroembolic kidney disease, right? Eosinophilia and as well as eosinophiluria, you will have atheroembolic kidney disease, right? And when you do a urine examination, there can be presence of even the cast. And electrolytes already I have discussed. Potassium is elevated, dilutional hyponatremia will be there, serum calcium level reduces, serum phosphate levels increases, and fraction excretion of sodium in pre-renal it will be less than 1, and in intrinsic renal it will be more than 1, right? And very important is the ECG. ECG will show you that there will be presence of tall T waves. Why is that you have tall T waves? That is because of the hyperkalemia. And next is the imaging, that is ultrasonography. This ultrasonography is more important in case of post-renal type of acute kidney injury, to look for benign prostatic hyperplasia, to look for ureteric calculi, to look for renal calculi, to look for bilateral ureteric fibrosis. That will be the importance of your USG. And next is the ABG, arterial blood gas analysis. The arterial blood gas analysis will show you that there is metabolic acidosis. Why is that? Because of loss of bicarbonate. Thereby, there will be metabolic acidosis. So these are the investigations that you will have in acute kidney injury. Now, how do you treat these patients? So treatment in case of acute kidney injury, it completely depends upon what is the underlying cause of acute kidney injury. Like for example, rhabdomyolysis, you need to do forced alkaline diuresis, right? If it is like, if there is like volume overload, you need to do salt and water restriction, and you need to give diuretics, that is you need to give furosemide, right? And for hypertension, we give labetalol. Because of the fluid overload, there can be hypertension causing fluid overload can cause hypertension, for which you need to give labetalol. And these patients can also have the dilutional hyponatremia causing the altered sensorium. So one is the fluid restriction, but if the individual develops symptomatic hyponatremia, then like symptomatic hyponatremia means what? Because of hyponatremia, there can be development of seizures. In these patients, you need to give 3% sodium chloride. And if the individual develops hyperkalemia, the drug of choice for hyperkalemia will be calcium gluconate. And next to the calcium gluconate, you need to give the other drugs. What are the other drugs? Like diuretics. Then your beta 2 agonist like salbutamol nebulization, right? And potassium binding agent, that is sodium polystyrene sulfonate, right? So these are the drugs that we give for hyperkalemia. And if there's metabolic acidosis where the pH of the individual is less than 7 and bicarbonate level is the, if it is less than 10, then you should give sodium bicarbonate, right? You should give sodium bicarbonate. Then hypocalcemia or hyperphosphatemia. See, whenever there is hypocalcemia, the individual will have the features of hypocalcemia. What is that? Perioral paresthesia and as well as periungual paresthesia, and there can be also tetany. So for them, you need to give calcium gluconate. Then how do you treat this? The hyperphosphatemia. The hyperphosphatemia, you need to give phosphate binding agents. What are those phosphate binding agents? That will be your calcium acetate, then sevelamer hydrochloride, then aluminium hydroxide. So these are the drugs that we give for hyperphosphatemia. That is phosphate binding agents like calcium acetate, sevelamer hydrochloride, and then aluminium hydroxide. Okay. Then next is the hyperuricemia. So hyperuricemia, you can have that in case of the tumor lysis syndrome. So whenever there is hyperuricemia, that is in tumor lysis syndrome, you need to give a uricosuric agent, and that particular uricosuric agent is rasburicase, right? Or you need to give a drug which will decrease the uric acid synthesis, and that will be allopurinol. That will be your allopurinol. So this is a treatment for your acute kidney injury. Next is hypertensive crisis. Already just now we have discussed. That is, we need to give labetalol, right? We need to give labetalol. Then followed by that, what is the indication for dialysis? The indication for dialysis, please remember this mnemonic, that is have P. H stands for refractory hyperkalemia. That means patient is not responding to your insulin supplementation, patient not responding to your beta 2 agonist salbutamol supplementation, patient not responding to your potassium binding agents. Refractory hyperkalemia, you need to do dialysis. And refractory acidosis, right? In spite of giving sodium bicarbonate, still acidosis is persisting, then do dialysis, right? And refractory volume overload. That means you have done salt and water restriction, you have given furosemide, but still there is volume overload. Do dialysis and take out the fluid. Elevated blood urea nitrogen, right? Blood urea nitrogen levels more than 35 millimoles, then you need to do dialysis. P stands for pericarditis, that is uremic pericarditis. E stands for uremic encephalopathy. E stands for the pulmonary edema, right? Pulmonary edema. So these are all the indications for dialysis, and this completes the discussion of your acute kidney injury, right? Now, once we are done with acute kidney injury, the next important topic is the chronic renal failure. So the definition of the chronic renal failure is based on the GFR. When the GFR, if it is less than 60 ml per minute per 1.73 meter square, along with that there is proteinuria, right? Along with that there is proteinuria which is being present for more than 3 months, then we consider it as the chronic renal failure. How much is a normal GFR? That is around 90 to 120 ml per minute. That is a normal GFR. But when the GFR reduces to less than 60, along with that proteinuria is there for more than 3 months, then we call it as the chronic renal failure. Right? Now, next important is we stage the chronic renal failure into stage 1, 2, 3, 4, 5 based on the GFR value. So, in stage 1, the GFR is more than or equal to 90, but there will be kidney damage. That means GFR is normal, but there is kidney damage, right? Whereas you take stage 2, kidney damage with mild decrease in the GFR. How much will be that? 60 to 89. Whereas in 3A, the GFR will be 45 to 59. Whereas in stage 3B, the GFR will be 30 to 44. Whereas in stage 4, the GFR is 15 to 29. When do you call end stage renal failure? When GFR is less than 15, then we call it as the end stage renal failure. Okay, so this is about the stages of the chronic renal failure. And this stage 5, we classify that into stage 5D and as well as stage 5T. 5D means the individual undergoing dialysis. 5T means the patient who has undergone the transplant. And what is the most common cause of chronic renal failure? Most common cause of chronic renal failure will be your diabetes mellitus. Now, what are the manifestations? The manifestations in patients with the chronic renal failure will be, number one, there will be renal osteodystrophy. What is renal osteodystrophy? See, these patients with chronic renal failure, they will have severe hypocalcemia because vitamin D will not be there. So whenever there is severe hypocalcemia, there will be increase in parathormone secretion causing bone resorption, causing renal osteodystrophy, right? The other important points are anemia because erythropoietin is not there. So there will be normocytic, normochromic type of anemia. And there will be leukopenia because of which there will be increased infection. And there will be also thrombocytopenia because of that there will be bleeding manifestations in these patients with the chronic renal failure. There will be growth retardation. Why is that? That is because of your anemia and renal osteodystrophy, there will be growth retardation. And you will have all the features of uremia. That is uremic encephalopathy, uremic pericarditis, uremic gastroparesis, everything will be there. And because of the fluid overload, the same features whatever we have discussed in acute kidney injury, pleural effusion, pericardial effusion, ascites and edema and hypertension will be there. And because of the accumulation of urea in the peripheral nervous system, there will be peripheral neuropathy. Gastrointestinal manifestations can be there, that is in the form of hiccups. They can also have the vomiting. So these are the GIT manifestations. And if you take the dyslipidemias, so there is decrease in lipoprotein lipase activity, right? There is decrease in lipoprotein lipase activity in chronic renal failure, and that is the one which will cause the dyslipidemia. And genitourinary manifestations, if you see, these patients, they will have impotency and isostenuria. Isostenuria means the specific gravity of the urine will be similar to that of specific gravity of the plasma. That will be the genitourinary manifestations. And what are the skin manifestations? These patients, they will have xerosis where there is drying of the skin, right? And they will have the bleeding manifestations. There will be like ecchymosis and there will be also edema. And why is this xerosis? That is because of accumulation of urea within the skin. Now, if you take this particular nails, they'll have this characteristic half and half nail. And this particular nail, it is also called as the Lindsay nail. Why is that? That is because of increase in the capillary density in the proximal half of the nail. And this is what is called Lindsay nail, or this is also called as the half and half nail. Then what will happen to the kidney size in patients with the chronic renal failure? the kidney size will be reduced in patients with the chronic renal failure. That's a very, very important point. Then how do you treat these patients with the chronic renal failure is very, very important now. So what is the most common cause for chronic renal failure? That is diabetes mellitus. So you have to see that the HbA1c of the individual is less than 7%, for which the treatment is insulin. Blood pressure should be under control, less than 130 by 90, for which we give labetalol or we give calcium channel blocker, right? Cholesterol, the LDL should be less than 70. LDL should be less than 70, and for maintaining the LDL less than 70 you need to give statins, right? And next thing is, these patients they have vitamin D deficiency, right? Because the kidney is damaged, so you need to give vitamin D supplementation. Along with the vitamin D supplementation, you need to give cinacalcet, right? Cinacalcet. And this particular cinacalcet, it prevents the release of parathormone, right? Cinacalcet prevents the release of parathormone. That is about your cinacalcet. Then next is erythropoietin, that is mainly to treat the anemia, and this is given subcutaneously. This is given subcutaneously. And what are the forms of erythropoietin? We have epoetin alpha and darbepoetin alpha, right? Epoetin alpha and darbepoetin alpha. So these are the erythropoietin supplements. That is mainly to treat the anemia, that is normocytic normochromic type of anemia. So this is what is the treatment of the chronic renal failure, right? Now, what is that we have discussed is about the renal replacement therapy. So when the GFR is less than 15, that means when the individual is in CKD stage 5, renal replacement therapy is done either by dialysis, right? Either by dialysis or renal transplantation. For doing dialysis, you need to create a fistula. That means those individuals who require long-term dialysis, every week, 2 times, 3 times dialysis is required. In them, you need to create an arteriovenous fistula. And this particular fistula is created between the radial artery and as well as the cephalic vein. And what is the name of the fistula? The name of the fistula is the Seminobrecia fistula. And this Seminobrecia fistula, the name is given in the honor of an Italian doctor because he is the one who has made this first. And the advantage of making the fistula is that there is reduced chances of development of thrombophlebitis, right? Thrombophlebitis chances can be decreased by your creating the fistula. And what is the principle of your hemodialysis? That is counter current mechanism. And most common complication of dialysis is hypotension, because you are taking out lots and lots of quantity of the fluid out of the body and you are sending it to your dialyzing machine. So hypotension is the most common complication. And most common complication of recurrent hemodialysis will be accelerated atherosclerosis, right? Accelerated atherosclerosis. And these patients who are undergoing dialysis, they also develop dialysis dementia. And this dialysis dementia, why is this dialysis dementia due to? This particular dialysis dementia is due to accumulation of the amyloid protein, right? And this amyloid beta 2 also gets accumulated in the flexor retinaculum, resulting in the carpal tunnel syndrome. And those individuals who are undergoing dialysis, there will be also B7 deficiency, resulting in burning foot syndrome, right? Resulting in burning foot syndrome. So these are the other complications, but most common complication is what? The hypotension. And most common complication of recurrent hemodialysis is what? That is accelerated atherosclerosis. And this particular dialysis can be done in two ways. One is your peritoneal dialysis and the other one is hemodialysis. Peritoneal dialysis, it can be done even in the home. It is slow process, but hemodialysis is usually done in the hospital and it is slightly the fast process. That is what is your peritoneal and as well as the hemodialysis. And in case of your peritoneal dialysis, remember what is that membrane which is being used, that is peritoneum itself will be used as a membrane for removing the impurities. Actually the peritoneum is filled with the dextrose solution, and into this particular dextrose solution across the peritoneal membrane the impurities will add and this dextrose solution is being removed. Okay, so that is what is your the peritoneal dialysis, right? Now, after having discussed about one form of renal, see there are two forms of renal replacement therapy. One is your dialysis and the other one is kidney transplantation. So if you take this kidney transplantation, which particular kidney is preferred? That is allogenic kidney is being preferred. That is from the first degree relative. And whenever you are doing kidney transplantation, HLA matching and blood grouping should be done mandatorily. The HLA matching is being done for which the gene is located on chromosome 6, and blood grouping is being done for which the gene is being located on the chromosome 9. And whenever you are taking the kidney from the donor has to be tested for HIV, the donor has to be tested for HBV, the donor has to be tested for the HCV, right? So, and even the cytomegalovirus. And in the recipient, what is that you have to do? You need to do the Doppler. Doppler has to be done in the recipient, that is mainly to rule out the renal artery stenosis. And which particular kidney of the donor is taken? That is left kidney of the donor has to be removed. Why? Because the left renal vein is longer, right? The left renal vein is longer. So left kidney of the donor has to be removed. And within the recipient, where do you keep this new kidney? This new kidney is placed in the right iliac fossa, right? It is placed in the right iliac fossa. Okay, right. And see, while doing kidney transplantation, definitely you have to do your HLA matching and blood grouping. But for liver transplantation, HLA matching is not required. Now, whenever you keep the kidney in the recipient, immediately what is the problem is the rejection. Because your kidney is being taken from a donor. It's a foreign body for the individual recipient. So rejection is very, very common. So hyperacute rejection, it's a type 2 hypersensitivity reaction. And this will occur within few minutes of anastomosis. Then next thing is acute rejection. Acute rejection is that which occurs within 6 months of surgery. And because it is occurring within 6 months of surgery, it is a type 4 hypersensitivity reaction. And next thing is chronic rejection. Chronic rejection is that which occurs after 6 months of surgery, and this is also a type 4 hypersensitivity reaction. And to prevent the rejection, you need to give the immunosuppressive agents. That immunosuppressive agents are, that is cyclosporin, then azathioprine, then prednisolone. These are the drugs that you need to give to prevent the rejection. Cyclosporin, azathioprine, and then the prednisolone. But whenever you are giving these immunosuppressants, the individual is at increased risk of the opportunistic infections, right? Now, what are the opportunistic infections that can occur within 1 month of giving the immunosuppressive drugs? Within 1 month, the individual is increased risk of the herpes simplex infection, or the individual can also have the MRSA infection. Within 1 to 6 months, the opportunistic infection that can be there is the pneumocystis jirovecii pneumonia and viral infections like cytomegalovirus, then HBV virus and HCV virus. And after 6 months of the chemotherapy or immunosuppressant therapy, the opportunistic infection here is the aspergillus, which is nothing but the fungal infection. Okay, so this is about your renal replacement therapy, right? Hemodialysis is one, then renal transplantation is the other one, right? So we are done with the chronic renal failure. The next topic is the renal tubular acidosis. So if you take this renal tubular acidosis, what are the types? We have type 1, type 2 and type 4 renal tubular acidosis. You don't have type 3, type 1, type 2 and as well as type 4, right? So let me discuss about type 1 renal tubular acidosis. See, type 1 renal tubular acidosis, this is also called as distal renal tubular acidosis. Where exactly will be the problem? The problem will be at the level of the collecting duct. And in these patients with type 1 renal tubular acidosis, let me tell you, it is not called Fanconi's syndrome. Fanconi's syndrome is what? It is type 2 renal tubular acidosis. And in these patients, they are at increased risk of calcium stone formation. And your renal tubular acidosis, it is hyperchloremic, right? It is the hyperchloremic, not normal anion gap metabolic acidosis, right? Hyperchloremic normal anion gap metabolic acidosis. So there is no anion gap. And in these individuals, they will also have the hypokalemia. So your type 1 renal tubular acidosis is what? Distal renal tubular acidosis. And what are the etiologies that can cause your type 1? That is some of the drugs. We have an antifungal drug called amphotericin B. This amphotericin B can cause your type 1 renal tubular acidosis. And not only that, the paraproteinemias, right? Paraproteinemias are nothing but your monoclonal gammopathies. Even they can cause your type 1 renal tubular acidosis. And what are the features of your type 1 renal tubular acidosis? Just now we have discussed that they will have the hypokalemia, right? And these patients, they will have metabolic acidosis, and there will be renal stone formation, that is the calcium stone formation will be there. And these patients, they will have the alkaline urine. They'll have alkaline urine. Then how do you treat these patients with type 1 renal tubular acidosis? See, they're having acidosis. So you need to give IV sodium bicarbonate, right? IV sodium bicarbonate. And this IV sodium bicarbonate that you are giving is, that is 2 to 3 milliequivalents per kg. That is what you have to give in type 1 renal tubular acidosis. Then you take type 2 renal tubular acidosis. Type 2 renal tubular acidosis, that is also called proximal. Whereas your type 1, it is distal renal tubular acidosis. So if you take type 2 renal tubular acidosis, which is also called proximal renal tubular acidosis, what is the etiology that will be causing your type 2? In type 2, the etiology is mainly the drugs. What are those drugs? That is carbonic anhydrase inhibitors. That is acetazolamide is the one which can cause your type 2 renal tubular acidosis. And the other condition is the plasma cell myeloma. Even this can cause your type 2 renal tubular acidosis. What exactly is the problem in type 2 renal tubular acidosis? At the point of PCT, there should be reabsorption of bicarbonate. And in type 2 renal tubular acidosis, the reabsorption of bicarbonate at the level of proximal convoluted tubule does not occur. That is what is your type 2 renal tubular acidosis, right? That is what is called type 2 renal tubular acidosis. And this type 2 renal tubular acidosis, this is also called as the Fanconi syndrome. This is also called as the Fanconi syndrome. And in these patients, there is no renal stone formation. There is no renal stone formation. And even in these patients also, they will have hypokalemia. But you don't have an alkaline urine, right? In these patients, they will have the urine of pH more than 5.5. The alkaline urine is classically seen in case of your, I'm sorry, the urinary pH here it will be less than 5.5. Whereas the alkaline urine is classically seen in case of type 1 renal tubular acidosis. Okay. Whereas in type 2 renal tubular acidosis, the urinary pH will be less than 5.5 and there is no renal stone formation in these patients. Now, how do you treat these patients with proximal renal tubular acidosis? You need to give IV sodium bicarbonate. This IV sodium bicarbonate, the dosage is 10 to 15 milliequivalents per kg, right? 10 to 15 milliequivalents per kg. That is what you have to give in case of your type 2 renal tubular acidosis. Whereas in type 1, 1 to 2 or 2 to 3 milliequivalents per kg of your sodium bicarbonate should be given. But here it is 10 to 15. Why? Because the problem itself is your bicarbonate loss. So that is the reason why you should give high dose of bicarbonate. Now, if you see the differences between proximal and as well as distal, proximal is what? It is your type 2. Distal is what? Type 1. Pathogenesis in type 2 is what? Failure of bicarbonate reabsorption in your type 2. Whereas problem in distal is what? There is defect in the secretion of the H plus. Right? There is defect in the secretion of the H plus at the level of the distal tubule. And growth failure is present in both of these conditions. And rickets and osteomalacia is also present in both of these conditions. Nephrocalcinosis is present in the type 1, absent in case of proximal renal tubular acidosis. And what are the other tubular effects? That is very common in case of the Fanconi. Your type 2 is your Fanconi, where you can have other tubular effects. Then coming to your type 4 renal tubular acidosis. See, type 4 renal tubular acidosis, this is due to aldosterone deficiency or the aldosterone resistance. See, what exactly is the function of aldosterone? Sodium and water retention, H plus ion secretion, and K plus ion secretion. The H plus and K plus should be out by your aldosterone. But here what is happening? Aldosterone is not there, or there is aldosterone resistance. So the H plus will increase. That will result in acidosis. And in these patients, they will also have hyperkalemia. See, the differential point is in your type 1 and type 2, you have hypokalemia. But this is the only condition where this is the only form of renal tubular acidosis where you will have the hyperkalemia. Then what are the drugs that will be causing your type 4 renal tubular acidosis? That is the drugs which will reduce your aldosterone levels. What are the drugs which will decrease the aldosterone synthesis? That will be ACE inhibitors. That will be the angiotensin receptor blockers, right? And your diuretics. Which particular diuretics? Aldosterone receptor antagonist, that is spironolactone and as well as the eplerenone. And one more drug is trimethoprim and as well as the pentamidine. So these are the drugs which can cause type 4 renal tubular acidosis. And apart from these drugs, you have some systemic conditions also. What are the systemic conditions? Diabetic nephropathy, interstitial nephritis, HIV, Addison's, sickle cell disease. All these can cause your type 4 renal tubular acidosis. And what is the treatment for type 4 renal tubular acidosis? Already there is high potassium. So dietary potassium restriction, right? The diet which is rich in potassium, like fruits, no fruits, coconut water, no coconut water, because they are the ones which are rich in potassium. And you need to give loop diuretics. This particular loop diuretics can cause the excretion of your potassium. Now what do we want? We want an aldosterone. So what is an aldosterone analog? The aldosterone analog is the fludrocortisone. So fludrocortisone is the drug of choice in case of type 4 renal tubular acidosis. So this completes the discussion of all the types of renal tubular acidosis, type 1, type 2 and type 4. Okay. So what type of acidosis is your renal tubular acidosis? Hyperchloremic normal anion gap metabolic acidosis, right? And see, there are some important points of differences from type 1, type 2, type 3. Type 1 and type 2 you will have hypokalemia. Type 4 will have hyperkalemia. Renal stone formation is there only in type 1. Type 2, type 4 you don't have the renal stone formation. Fanconi syndrome. Only your type 2 is called Fanconi. The remaining type 1 and type 4, it is not Fanconi. Right? So these are some of the differences that you need to know among all these forms of renal tubular acidosis. Right? Now, after having discussed about the renal tubular acidosis, now let me take up the discussion of renal vascular disorders. You see this question. A 10-year-old child develops hematuria after 2 days of the diarrhea. The blood film shows the fragmented RBC and thrombocytopenia. Ultrasound shows marked enlargement of both the kidneys. So, what do you think is the likely diagnosis in this patient? Acute pyelonephritis, disseminated intravascular coagulopathy, hemolytic uremic syndrome, renal vein thrombosis. So, what does this clinical picture appears like? Actually, you may think the clinical picture is suggestive of the hemolytic uremic syndrome, right? But the answer is not hemolytic uremic syndrome. The answer is renal vein thrombosis. Now, why the answer being renal vein thrombosis? Remember, in hemolytic uremic syndrome, you will have normal sized kidneys. Now, the presence of enlarged kidneys that makes the answer as renal vein thrombosis. Okay, so marked enlargement of both the kidneys, it is suggestive of renal vein thrombosis. But only the difference, the only problem is whenever there is bilateral renal vein thrombosis, there will be bilateral enlargement of the kidneys. That particular time, it is difficult to distinguish the hemolytic uremic syndrome. It is difficult to distinguish hemolytic uremic syndrome. And this particular renal vein thrombosis, it is preceded by the gastroenteritis in both children and as well as adults, right? What is the most common cause of your renal vein thrombosis in children? That is the gastroenteritis. See, gastroenteritis will cause very severe dehydration, and this particular dehydration will precipitate for the development of the renal vein thrombosis. Whereas you take in adults, the most common cause of renal vein thrombosis will be membranous glomerulonephritis, right? Membranous glomerulonephritis. Okay. Then now, how will you diagnose renal vein thrombosis? That is by Doppler flow study. So when you do a Doppler flow study, right, or angiography of inferior vena cava, that will confirm the diagnosis of renal vein thrombosis, right? And what is the treatment? Because it's a renal vein thrombosis, you need to give the anticoagulant. So the very important point is in these patients, there will be marked enlargement of both the kidneys. And in these patients, you take in children, the important etiology is the preceding gastroenteritis. So if you see this particular question, our patient is having the preceding diarrhea. And in these patients, you can have the fragmented RBC and there can be also thrombocytopenia. So these are the features of the renal vein thrombosis. Now, one more important renal vascular disease. So just now what we have discussed is renal vein thrombosis. Next is the renal artery stenosis, right? So what do you think is the most common cause of renal artery stenosis in young adults in India? The options are atherosclerosis, non-specific aortoarteritis. Then the other options are fibromuscular dysplasia, none of the other. So you take in young adults in India, that will be non-specific aortoarteritis. Atherosclerosis is the most common cause of renal artery stenosis in adults, that is old patients, whereas fibromuscular dysplasia is the most common cause of renal artery stenosis in young patients in Western countries. Right, in Western countries, the fibromuscular dysplasia is more common in young adults, whereas in India, it will be non-specific aortoarteritis, right, which is nothing but your Takayasu. Now, what do you think is the clinical features that you will have in patients with a renal artery stenosis? See, in renal artery stenosis, these patients, they will present with very severe hypertension. Why? Because of because of activation of RAS. And bilateral renal artery stenosis, it is present in almost 50% of cases. And these patients, they can have episodic or they will have recurrent flash pulmonary edema, right? They will have recurrent flash pulmonary edema, and whenever there is recurrent flash pulmonary edema, they are the candidates who have to undergo renal artery stenting. They have to undergo renal artery stenting. And when you do examination, right, when you do examination of the abdomen, you will listen a bruit, right? You will listen a bruit over the abdomen. So these are the clinical features of the renal artery stenosis. Now, what is the screening procedure of choice? The screening procedure of choice is gadolinium enhanced magnetic resonance angiography, right? Gadolinium enhanced three-dimensional magnetic resonance angiography, that is the screening procedure of choice. And what is the confirmatory test? The confirmatory test is contrast enhanced arteriography, right? Contrast enhanced arteriography, right? Then how do you treat? See, if there is like unilateral renal artery stenosis, you can give the ACE inhibitors or the angiotensin receptor blockers. But when there is bilateral renal artery stenosis, the ACE inhibitors, they are absolutely contraindicated. They're absolutely contraindicated. And whenever there is bilateral renal artery stenosis, either you need to do surgical treatment, that is PTRA. That is, what is PTRA? That is percutaneous transluminal renal angioplasty has to be done when there is bilateral renal artery stenosis, right? And usually these patients with bilateral renal artery stenosis, they present with recurrent flash pulmonary edema and they will be requiring this PTRA, right? So that is about your renal vascular disorders, that is renal vein thrombosis and renal artery stenosis. Now we will move on to the next important, that is the nephrotic syndrome, right? So we'll discuss nephrotic and as well as nephritic. So what all we have finished until now? Acute renal failure, chronic renal failure, renal replacement therapy, renal tubular acidosis, then renal vascular disorders, right? The renal vein thrombosis and renal artery stenosis. We are done. Now let me discuss about the nephrotic syndrome. So in nephrotic syndrome, you will not only have renal, you also have extra renal manifestations as well. What are those renal and extra renal? See, the investigation of choice will be proteinuria. And how much will be the proteinuria? More than 3.5 grams per 24 hours. That is the investigation of choice. And the protein which is predominantly excreted is albumin. So that is the reason why these patients, they will also have hypoalbuminemia. And because of hypoalbuminemia, they present with edema. Apart from this, the other manifestations in nephrotic will be, there will be hyperlipidemia, there will be hypercoagulability, right? And you will also see the presence of the lipiduria. So what is this lipiduria? Lipiduria is the presence of the oval fat bodies within the urine, right? Presence of oval fat bodies within the urine. So these are the manifestations in patients with the nephrotic syndrome, and the predominant protein which is being lost is albumin. But let me tell you, in nephrotic syndrome, it is not only the albumin which is being lost. These are all the other proteins which are being lost. See, transferrin is being lost. So because of which the patient can present with iron deficiency anemia. Polycalciferol binding protein is being lost. So that is the reason why the patient can have hypocalcemia. Thyroxine binding globulin is being lost. So that is the reason why they can have thyroid abnormalities. Ceruloplasmin is being lost. So that is the reason why there will be impairment in the metabolism of your copper. Antithrombin 3 is being lost. That is the reason why there is increased the coagulation. Immunoglobulin is being lost. So these individuals, they are at increased risk of infections. So these are the other proteins which are being lost, but the predominant protein which is being lost is the albumin, right? Next, the next important thing is the coagulation factors. See, these patients with nephrotic syndrome, there is hypercoagulability. Why? Because there is increased synthetic capacity of the liver as a compensatory process of increasing the albumin synthesis. So there is increase in the synthesis of coagulation factors. Which all coagulation factors are increased? That is, increase in the factor 1, that is your fibrinogen, right? And next to this, there is increase in your factor, that is labile factor. Increase in the factor, that is stable factor. Increase in, right, increase in factor 8 and increase in factor 12 and increase in factor 13. So these are the coagulation factors which are increased in patients with the nephrotic syndrome. And not only that, the other cause for the hypercoagulability in nephrotic syndrome is, apart from increase in the coagulation factors, there is also decrease in the natural anticoagulants. What are natural anticoagulants? Protein C and protein S. This protein C and protein S is being lost. So once this particular protein C and protein is being lost, that is also the factor that will contribute to the development of the hypercoagulability. And you should know what are the causes of nephrotic syndrome. Most common cause of nephrotic syndrome in adults will be diabetes mellitus. Most common cause of nephrotic syndrome in children will be minimal change disease. And the most common, I'm sorry, one second. In adults, the most common cause of nephrotic syndrome will be focal segmental glomerulosclerosis. And what is the most common systemic disease that can cause nephrotic syndrome will be diabetes mellitus, right? And what is the most common cause of nephrotic syndrome in elderly individuals, right? That will be membranous glomerulonephritis. Okay, so these are all the etiologies that will be causing where you will have the nephrotic syndrome, right? Now let me take up the discussion of these individual forms of nephrotic syndrome as a quick recap. Now you see this question: a 7-year-old boy presented with the generalized edema. Urine examination revealed marked albuminuria, and serum biochemical examination showed the presence of the hypoalbuminemia with hyperlipidemia. The kidney biopsy was undertaken. On light microscopy, the kidney appeared normal. Electron microscopy, what exactly will be the finding? See, this entire picture in a 7-year-old boy, what is it suggestive of? This is suggestive of minimal change disease. Electron microscopy picture in minimal change disease, what is that you will observe? You will observe that there is fusion of food processes, right? Fusion of food processes. Okay. Now, let me take, and so in case of minimal change disease, light microscopy will be absolutely normal. Electron microscopy is the one which will show you the fusion of the food process. And what is the drug of choice in patients with minimal change disease? That is, you need to give prednisolone, right? Those individuals who have steroid resistant minimal change disease, in them you need to give cyclosporin or cyclophosphamide can be given, right? In steroid resistant nephrotic syndrome of minimal change disease, right? Next, so that was the nephrotic syndrome in children. Electron microscopy will show you the fusion of the food processes, right? Right. Then you take the diabetes mellitus. So diabetic nephropathy, that is the most common cause, most common systemic disease that can cause the nephrotic syndrome. In diabetic nephropathy, if you take a biopsy, you have the features like diffuse glomerulosclerosis, and you have the features like nodular glomerulosclerosis. But which is more common between these two? Diffuse is more common than compared to that of nodular glomerulosclerosis. And what will be the earliest manifestation in diffuse glomerulosclerosis? The earliest manifestation in diffuse glomerulosclerosis is thickening of the glomerular basement membrane. That is the earliest manifestation. And you also have the exudative lesions, that is capsular drops and fibrin caps. Whereas in nodular glomerulosclerosis, the presence of nodular glomerulosclerosis, that will be pathognomic of your diabetic nephropathy. And what is the name of these lesions in case of nodular glomerulosclerosis? These particular lesions, they are called as the KW lesions, that is called Kimmel-Steele-Wilson's lesions, or these are also called intercapillary glomerulosclerosis, right? This is also called intercapillary glomerulosclerosis. So this is what is called nodular glomerulosclerosis, right? So these are the two forms in the biopsy, diffuse and nodular. Most common diffuse, pathognomic is nodular, and that is nothing but your Kimmel-Steele-Wilson lesion, right? And what is the drug of choice for diabetic nephropathy? That is, the ACE inhibitors should be given for diabetic nephropathy. And you take the minimal change disease. Just now we have discussed about the minimal change disease. What is that? Light microscopy, no abnormality. Electron microscopy, fusion of the food process. And immunofluorescent microscopy, you don't have the immunoglobulin or complement, right? Immunofluorescent microscopy, there is absence of immunoglobulin or complement. That is what is the picture in case of minimal change disease. Then focal segmental glomerulosclerosis. Focal segmental glomerulosclerosis, it is the most common form of nephrotic syndrome in adults. So if you take, you should know light microscopy, electron microscopy and fluorescent microscopy. You take light microscopy. Light microscopy, it will show you that it is not the entire glomerulus, it is the part of the glomerulus which is involved, right? It is the part of the glomerulus which is being involved, and it is only some segments of glomerulus which are being involved in light microscopy. Whereas electron microscopy, if you see, you will observe the presence of the hyaline deposits. Fluorescent and not only that, the electron microscopy, you will also notice the podocyte foot process effacement, right? There will be effacement of the podocyte foot process, and there will be also hyaline deposits. And fluorescent microscopy, that will be normal. That means there is no immunoglobulin in case of the fluorescent microscopy in focal segmental glomerulosclerosis. And this focal segmental glomerulosclerosis, this is also called as reflux nephropathy. This is also called reflux nephropathy. And this focal segmental glomerulosclerosis, it mainly occurs due to reflux of the urine from the bladder to the kidney. There will be hydronephrosis in focal segmental glomerulosclerosis, right? And this focal segmental glomerulosclerosis, one of the very important etiologies, HIV. Thus we call it as HIVAN, HIV associated nephropathy, right? Then you take the biopsy picture in membranous glomerulonephritis. Membranous glomerulonephritis, what did I tell you? Right, it is the most common form of nephrotic syndrome in elderly individuals. So if you take light microscopy, electron microscopy, and fluorescent microscopy. So in light microscopy, in membranous glomerulonephritis, you will have the characteristic spike and dome pattern, right? Spike and dome pattern. And this particular spike and dome pattern results from projections of the excessive glomerular basement membrane. Okay, so you will notice that there is spike and as well as dome pattern. And what is the stain we used? That is methenamine silver stain we use, right? The stain what we use to look for spike and dome pattern, methenamine silver stain. Now, when you do an electron microscopy, you will be able to make out what is the cause of this spike and dome pattern. So you will have the subepithelial deposits, and that is what is responsible for the spike and dome pattern. And the fluorescent microscopy, you will observe that there is IgG and as well as C3 in case of the membranous glomerulonephritis. Okay, so this is the biopsy picture in membranous glomerulonephritis. So, right, so to quickly recap, in diabetic nephropathy, you have diffuse glomerulosclerosis, most common, and nodular glomerulosclerosis, that will be pathognomic, that we call it as Kimmel-Wilson lesion. Minimal change disease, light microscopy, no abnormality. Electron microscopy, you will have the fusion of foot process. Focal segmental glomerulosclerosis, light microscopy will show you that only few glomeruli are being affected. In electron microscopy, you will have the presence of the hyaline deposits and effacement of the foot process. Membranous glomerulonephritis, light microscopy, you will have the spike and dome pattern. Electron microscopy, you will have subepithelial deposits. Fluorescent microscopy, you will have IgG and as well as the C3, right? And in diabetic nephropathy, ACE inhibitors are the drug of choice. Minimal change disease, you need to give steroids. And even in focal segmental glomerulosclerosis, we give steroids. And here, membranous glomerulonephritis, along with steroids, they also require the other drugs like cyclophosphamide or cyclosporin or your these are the other immunosuppressive drugs that can be given in case of membranous glomerulonephritis. Okay, so with this, we are done with the topic related to nephrotic syndrome. And these patients with minimal change disease, you have to remember one important point: they have good prognosis, right? Very good prognosis will be there in these patients with the minimal change disease, right? So with this, we are done with the nephrotic syndrome. And this is what is your focal segmental glomerulosclerosis. What did I tell you? It is called as reflux nephropathy. So you will observe that there is a hydronephrotic kidney, and in the light microscopy you will observe that it is only the part of the glomerulus which will undergo the sclerosis. And what are the etiologies that will be causing focal segmental glomerulosclerosis? It is mainly the infectious pathology like HIV. And other infections are HBV, human papillomavirus, hypertensive nephropathy, heroin addiction, sickle cell anemia, massive obesity. All these can cause the focal segmental glomerulosclerosis, right? So with this, we are done with the topic related to nephrotic syndrome. Now we'll move on to the discussion related to the nephritic syndrome. So if you take nephritic syndrome, the very important point in nephritic syndrome is the proteinuria. But how much will be the proteinuria? That will be 3 grams per 24 hours. And in these individuals, they will have hematuria. Usually in nephrotic syndrome, you don't have hematuria except for focal segmental glomerulosclerosis. But hematuria is very classical in case of the nephritic syndrome, right? And these patients, they will also have hypertension and they will also have the oliguria, right? And in all the forms of nephrotic syndrome, you don't have hypertension. In minimal change disease, the blood pressure will be normal. But in all the forms of nephritic syndrome, there can be hypertension. And what are the forms of your nephritic syndrome? See, the nephritic syndrome, right? You have IgA nephropathy, and as well as post-streptococcal glomerulonephritis, and as well as the Goodpasture syndrome. Right? Let me discuss these three important conditions now. You take IgA nephropathy. See, these patients with IgA nephropathy, they present with the early hematuria, right? That means the hematuria will be there within 2 to 4 days of the infection. Within 2 to 4 days of infection. And this IgA nephropathy is also called as Buerger's disease, and the hematuria will be recurrent gross hematuria. Recurrent gross hematuria, right? And these patients, complement levels will be normal, right? ASO titer will not be elevated. ASO titer will not be elevated in these patients with the IgA nephropathy or Buerger's disease. But very important is, in IgA nephropathy, you need to know the biopsy. What will the light microscopy show in IgA nephropathy? You will observe that there is mesangial proliferation in IgA nephropathy. Whereas the fluorescent microscopy, you will see that there is presence of IgA and as well as C3 within the mesangium. And electron microscopy, right? Electron microscopy, you will observe that there is mesangial and as well as paramesangial deposits. Mesangial and paramesangial deposits. That is what is the story of your IgA nephropathy or Buerger's disease. What will be the biopsy picture, right? Then you take post-streptococcal, and in these patients with IgA nephropathy, let me tell you, serum IgA levels, there is no diagnostic value. It should be the renal IgA levels. That means the fluorescent microscopy IgA levels, that should be high, and that is what is the diagnostic picture in case of the IgA nephropathy. And how do you treat this IgA nephropathy? We give steroids. Along with steroids, we also give cyclophosphamide. So steroids and as well as the cyclophosphamide, they are very important in case of the IgA nephropathy. Then post-streptococcal glomerulonephritis. See, post-streptococcal glomerulonephritis, as the word itself tells you, it is secondary to group A beta hemolytic streptococcal throat infection and as well as skin infection. And light microscopy, what is that you will observe? Light microscopy, you will have that there is presence of diffuse proliferative glomerulonephritis. Right? Diffused proliferative glomerulonephritis. And you will observe that there is infiltration of the neutrophils, right? Infiltration of the neutrophils within the capillary lumen, right? And you will have the characteristic starry sky appearance. Characteristic starry sky appearance. Okay. And when you do an electron microscopy, you will see the presence of the humps. You will see the presence of humps. What are these humps? These are nothing but dome shaped subepithelial deposits, right? Dome shaped subepithelial deposits, right? And immunofluorescent microscopy, that will show you the presence of C3 and as well as the IgG. That is what is your post-streptococcal glomerulonephritis. Okay, right. Now coming to, in post-streptococcal glomerulonephritis, the treatment is completely symptomatic treatment, and we don't give any antibiotic because the infection was long back. It is not the present infection, so there is no role of antibiotic. If these patients develop hypertension, you need to give antihypertensives. So symptomatic treatment should be given in PSGN, and these patients, they have good prognosis. They will not have any recurrence. There is no recurrence in PSGN. But in case of IgA nephropathy, the recurrence is very high in IgA nephropathy, but there is no recurrence in PSGN. Coming to your Goodpasture syndrome. So if you take Goodpasture syndrome, it is an autoimmune disease, right? Where the antibodies, are being formed against alpha 3 chain of type 4 collagen, right? The antibodies are formed against alpha 3 chain of the type 4 collagen of the basement membrane within the kidney, of the basement membrane of the alveoli, right? Of the basement membrane of the kidney and alveoli. So when the antibodies are formed against the basement membrane of the kidney, these patients, they develop rapidly progressive glomerulonephritis and they can have hematuria. And when the antibodies are formed against the basement membrane of the alveoli, these patients, they can develop intraalveolar hemorrhage, and that too, it is focal necrosis of the alveoli. It is not the diffuse necrosis of alveoli. Please remember, this is an important MCQ, right? It is a focal necrosis of alveoli causing intraalveolar hemorrhage, causing hemoptysis, right? Causing hemoptysis. So hematuria and hemoptysis is a classical presentation in patients with the Goodpasture syndrome. So even though it's an autoimmune disorder, it is more common in males than compared to females. The ratio is almost like 6:1. And what is the investigation of choice here? The investigation of choice is anti-glomerular basement membrane antibodies. The sensitivity of this test is almost 90%, right? And what you will see in the biopsy, actually, the renal biopsy is the gold standard investigation. Renal biopsy is the gold standard investigation. So in the renal biopsy, you will observe that there is diffuse proliferative glomerulonephritis. And when you do an immunofluorescence, immunofluorescence will reveal the linear deposits. Okay, so that is what is your Wood-Passage syndrome. And how do you treat these patients with Wood-Passage syndrome? You need to do plasmapheresis. Whenever you do plasmapheresis, that will take out the antibodies. So that is about your Wood-Passage syndrome. So Wood-Passage syndrome, it is the one which will cause nephritic syndrome. It's an autoimmune disorder. The antibodies are being formed against alpha 3 chain of type 4 collagen of alveolar and as well as glomerular basement membrane, causing hematuria and as well as the hemoptysis. Serology, anti-glomerular basement membrane antibodies are present in almost 90% of patients, and the investigation of choice is renal biopsy, which will show you diffuse proliferative glomerulonephritis, and immunofluorescence will reveal the linear deposition. And the treatment is plasmapheresis that will take out the existing antibodies. After doing plasmapheresis, you need to give a combination of, right, you need to give a combination of plasma exchange and as well as the corticosteroids. So these corticosteroids can be combined with azathioprine. So these corticosteroids and azathioprine, that will prevent the new antibody formation. Okay, so that is about your Wood-Passage syndrome, which will be your nephritic syndrome. Okay, right. Now after having discussed about the nephritic, we will move on to the hereditary disorders of the kidney. So what are the hereditary disorders of the kidney? Like you have Barter's, Gitelman's, Alport's, and even Liddle's. So in Barter syndrome, what exactly is seen? In Barter syndrome, what is the problem? Metabolic acidosis, then hypokalemia, hyperkalemia, decrease in the urinary calcium. So first of all, let me tell you what exactly is your Barter's, and then we'll come back to this question. See, Barter's, it is the one where the pathology resembles the loop diabetic. See, Bartter syndrome, like we have type 1 to type 5. So, type 1 to type 4 is autosomal recessive type of inheritance. Type 5, it is autosomal dominant type of inheritance. And this Barter's, it resembles what? Loop diabetics. That means what? That means in Barter's, there will be defect in sodium potassium 2 chloride channel. Where is this sodium potassium 2 chloride channel? That will be present in ascending limb of loop of Henle. And even your loop diuretics will also inhibit the sodium potassium 2 chloride channel. So remember, in Barter's, it resembles the loop diuretics because the pathology will be in the sodium potassium 2 chloride channels. Now in these patients, what all will be the abnormalities? Let me discuss. See, in these patients, we have, I said you, we have 5 types of Barters. So out of which your type 1 to type 4, it is autosomal recessive, and type 5, it is the autosomal dominant type of inheritance, right? Now, what will be the clinical presentation in these patients with the Barters? See, this is what the appearance of the individual with the Barters. So they will have this characteristic triangular faces. The eyes will be very large eyes, and you take the ear pinna, they'll have large ear pinna, and they will also have the renal failure. And these patients, they also have sensory neural hearing loss, like your Alport syndrome. Patients early in the life, they can also have sensory neural hearing loss. And the classical clinical presentation in these patients with the Barter's is they will have polyuria, they will have polydipsia, along with that, they will have hypokalemic metabolic alkalosis, right? Hypokalemic metabolic alkalosis, and the blood pressure will be normal. That means without hypertension. So hypokalemic metabolic alkalosis without hypertension, that is what is the classical presentation in case of the Bartter syndrome. So if you go back to this question, right, if you go back to the question, right, metabolic acidosis will be there and hypokalemia will be there, but hyperkalemia will not be there, and there will be decrease in the urinary calcium concentration. So, once again, the question asked is what? Which of the following is being seen? So, in these individuals, like what is being seen? It is your hypokalemic metabolic alkalosis. I'm very sorry. I'm very sorry. It is hypokalemic metabolic alkalosis. Okay, not metabolic acidosis. Hyperkalemia will not be there. And what will happen to your urinary calcium? There will be increase in the urinary calcium levels. I'm very sorry for that. So the answer will be hypokalemic metabolic alkalosis. So that is what is your Bartter syndrome, right? And in Bartter syndrome, even your renal prostaglandin E2 levels, they are elevated, right? So your urinary calcium levels, either they are normal or being elevated. That is what you will see about the urinary calcium in case of the Bartter syndrome. What is the age of presentation of the Barters? That is usually early in the life. Predominantly, it is autosomal recessive. Only type 5 Barrett's, it is autosomal dominant type of inheritance, right? Then, followed by that, we'll move on to the discussion of the Gentleman syndrome. Okay. So, if you take this Gentleman syndrome, this will resemble the thiazide diuretics, right? This will resemble the thiazide diuretics. And here also, it is autosomal recessive type of, right? Here also, it is autosomal recessive type of inheritance. And what is the problem in Gentleman's? When we are telling that it is resembling thiazide diuretic will act at the level of distal convoluted tubule. It will block the sodium chloride symporter. That is what the thiazides do. And in Gentleman's, the problem is this particular channel, that is sodium chloride symporter or co-transport, does not work. There is a defect in this particular channel. And the age of presentation will be late childhood. The age of presentation will be late childhood. And these patients, the blood pressure in these individuals will be absolutely normal. And even these patients also, they will have polyuria. Even these patients also, they'll have polyuria. And in these patients, how do you diagnose? If you take, they will have chloride resistant metabolic alkalosis. And these patients also, they will have hypokalemia similar to that of your Barrett's. And these patients, if you take the magnesium levels will be reduced. That is one of the very important difference between Gentleman's and Barrett's. In Barrett's, the magnesium levels will be normal serum magnesium in Barrett's. But whereas, right, normal magnesium level in Barrett's. Whereas in Gentleman's, the magnesium levels will be reduced. That's one of the important point of difference. Now, why is that the magnesium levels are being reduced? Because there will be also defect in TRPM6 in Gentleman syndrome. TRPM6 is the one which will reabsorb the magnesium. So there will be decreased serum magnesium levels, right? And what will happen to your urinary calcium excretion? There will be also decreased urinary calcium. But what was the calcium in Barrett's? The urinary calcium was normal. The urinary calcium was normal, or occasionally it may be increased, but here the urinary calcium levels will be reduced. So that is another important point of difference between Gentleman's and as well as Barrett's. But both of them, please remember, they will have hypokalemia. Both of them, please remember, they will have normal blood pressure. They will have normal blood pressure, right? So this is about your Barrett's and Gentleman's. Barrett's resembling loop diuretics, Gentleman's that will resemble the thiazide. Okay, right. Now, once we are done with these two, the next important is the Alport syndrome. The next important is the Alport syndrome. So now what will be the, okay, one more. Yes, you see this. Hypertension with hypokalemia. Where do you come across this? You come across this in Liddle syndrome, right? Now, what is this Liddle's? Liddle's is increase in the ENaC activity, right? Increase in the epithelial sodium channel activity. And once there is increase in epithelial sodium channel activity, there will be sodium and water retention causing hypertension, and there will be potassium excretion causing hypokalemia. There will be H plus ion excretion causing metabolic alkalosis. And remember, in Liddle's, what is the drug of choice? See, you want to block this ENaC, so you need to give epithelial sodium channel blocker. What is that particular epithelial sodium channel blocker? Like we have amiloride, then triamterene. Right? Amiloride and as well as triamterene. So this is about your Liddle syndrome. Okay. So in all these, whatever we have discussed until now, you take Barrett's, you take Gentleman's, you take Liddle's. In all of these, you have the metabolic alkalosis and you have the hypokalemia. Right? You have the hypokalemia. Right? Whereas in Barrett's and Gentleman's, hypertension is not there, but in Liddle's, you have the hypertension. Okay. Right. Now, next is about the, yes, you see this question. So, mutation in alpha 5 chain of type 4 collagen. See, if the mutation is there in alpha 3 chain of type 4 collagen, good pastures. But if the mutation is there in alpha 5 chain of type 4 collagen, that becomes your Alport syndrome. So, Alport syndrome, it is characterized by a classical triad. What is that classical triad? Number one, there will be hereditary nephritis, because of which they can have the hypertension. They can have the hypertension. Next, these patients, they will have sensory neural hearing loss. Why? Because your alpha 5 chain of type 4 collagen is also present within the cochlea. It is also present within the cochlea. So that is the reason why there is sensory neural hearing loss. And this alpha 5 chain of type 4 collagen is also present within the cornea or within the eye. So the ocular abnormalities will be in the form of anterior lenticonus, right? Ocular abnormality will be in the form of anterior lenticonus. And these cornea ulceration will be there. There will be recurrent corneal erosions, and not only that, these patients will also have the cataract. So this is a triad in Alport syndrome. So hereditary nephritis, and because of hereditary nephritis, they can also have the hematuria. They can also have the hematuria. So hematuria, that is the earliest manifestation in patients with the Alport syndrome. Earliest manifestation, right? And what is the most common extrarenal abnormality? Most common extrarenal abnormality will be the sensory neural hearing loss. And most common ocular abnormality will be the anterior lenticular. Okay, so this is about your hereditary disorders of the kidney. So Barter's, please remember, it will resemble the loop diuretics. Gittelman's, please remember, it will resemble the thiazide diuretics. Liddle syndrome, that is due to increase in the ENaC activity. Alport syndrome, that is due to defect in alpha 5 chain of type 4 collagen, because of which you have a classical triad, that is hereditary nephritis, sensory neural hearing loss, and then ocular abnormalities. So with this, we are done with the entire nephrology revision. Right, with this we are done with the quick revision of the entire nephrology. Okay, so with this I'll wind up this particular session of today, wherein we have discussed neurology and as well as the nephrology. So I'll be sending you this PDF with annotations on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, wherein you can download from it, and then you can do a quick revision for your exam. What will be the tomorrow session? The tomorrow session will be the pulmonology, that is respiratory system, right? And the other important topic is the connective tissue disorder, right? So at 7 o'clock, same time, let me just come back to you for doing the quick revision on pulmonology and as well as connective tissue disorder, right? Thank you very much. See you tomorrow at 7 p.m.